Employee Benefits Board here at the Oregon Health Authority, here on behalf of the Oregon Health Authority, and I welcome you to our April meeting. Thank you so much to those of you who are able to be here in person. And I'd like to call this meeting to order. First item on the agenda is to take a look at the meeting minutes. Board members, have you had a chance to take a look? Before we do that, let's do roll call. Excuse me. Siobhan Martin.
I am present.
Greg Klauser.
Here.
Morning, Greg. Cheeky Flowers. Not hearing Cheeky. We'll come back to Cheeky. She'll be a little late this morning. Andrea Fultz.
Andrea is listening in, but she's not able to participate via.
Okay.
She can't vote.
Okay. Thank you. Kimberly Hendricks.
Here.
Morning, Kimberly. Sean Parkman.
Here.
Morning, Sean. Emily Wong.
I'm here, and I'll be in person, but closer to 10:45-ish. Lots of traffic.
Thank you, Emily. Good morning. Okay. With that, I believe we have a quorum, correct?
Yes.
Okay. Thank you. And would you like to proceed with some?
Yes, logistics, there's restrooms out that door right there. Wi-Fi is guest. And it looks like it doesn't work at first, but it actually does. So, you know.
Okay. And to the minutes, board members, have you had a chance to take a look?
I have reviewed the minutes and I will make a motion that we approve them as written.
I can second that.
We have a motion and it's seconded. All in favor of approving the minutes as written, say aye.
Aye. Aye.
Thank you. Any opposed? We need to vote for one. And the minutes are approved as written. Thank you. And I will welcome Andrew Hoffheimer and Emery Chen from Mercer to give the first presentation here about the round 3 renewals.
Thank you so much. Hi, everyone. It's great to see you all in person. We've got about a little under 3 hours for this next part of the discussion today. And so myself and Emery and some other colleagues from Mercer are going to be leading us through these slides. We've got a lot of really interesting content, and so I am confident this is going to be a really robust discussion, and we're looking forward to it. So let's jump to the next slide, and I'll just spend a couple of minutes getting you oriented to the flow of the content over the next 2.5 or 3 hours or so. And so we'll start off with just spending a couple of minutes revisiting first the PEBB values, which sort of become really relevant this time of year as we get closer and closer to asking board members to make decisions for the 2026 renewal. So we'll talk about that for a few minutes. We'll also revisit the balanced approach to achieving 3.4% cost increase in 2026. And so we'll review sort of the 4 broad categories that are available. Those categories are at a pretty high level, and we'll obviously get a lot more specific as we go through the content today. Most of our time today is really going to be in this second section here. And so this will, as Dawn, you mentioned, this will be our continuation in the renewal discussion. And so we will start that off with getting board members updated on the financial position for the cost projections for 2026. And so we'll show you that in aggregate. We'll show it to you in composite so that you can see what has changed relative to the position to 3.4%. We will also look at the status of the low-cost plans and talk about that as well. And after we've updated you on the financials, we thought we would first move into dental, vision, and supplemental renewals. These were benefits that we didn't actually get to last month because we had spent the entire discussion on medical, which is okay. But these are important benefits too. So we thought we'd start there and then work our way through before shifting gears to medical. The medical renewal will be some sort of new content. There are some new emerging topics that we've included for discussion today, as well as pulling forward some topics that we talked about last month where perhaps there are updates, that sort of thing. And our goal really is to work towards those scenarios to get to 3.4%. And so we're not asking board members to vote today. To the extent that you're ready to vote on some items, that's totally fine. But if there are follow-ups or additional information that's needed, that's totally okay. We can use the May 20th board meeting for final decisions for 2026. Okay, with that said, let's spend a couple of minutes. Next slide, please. Oh, perfect. Talking about a slide that I know you're all familiar with, so we probably don't need to spend a ton of time here, but we've got PEBB's core values on the left: so quality of care, centering decisions within equity, portability, and member experience. And so when we get to the scenarios, which is towards the end of the deck, we're going to show you maybe 20 or so different options to reduce costs in 2026. And so some of those, focus more heavily on one or another of those values. And some of those 20 options are kind of straightforward, and some of them are a little bit less black and white. And so for those options that are less black and white, we're hopeful that these questions and this decision-making framework that we have on the right be sort of a handy reference tool for board members as you evaluate what makes sense and what is the right strategic balance to achieve 3.4%. And so we just wanted to get these in front of you in case that's helpful for that part of the discussion once we get to the scenarios. This is another slide that you've all seen before, obviously super relevant for our discussion today as we continue to try to solve for the excess cost above 3.4%. The number continues to be on the larger side. I think it's down a little bit from round two, but it continues to be a significant dollar amount that collectively we're trying to solve for to hit that statutory 3.4% cap. And so what that means is that we're really exploring each of these four levers to again try to reach consensus on what's the appropriate balance to achieve 3.4%. And so, conducting negotiations, this one is sort of self-evident. We review underwriting methodology, factors that are used, make sure that those are fair and competitive. Improving efficiency can sort of come in a couple of different flavors. One is efficiency through, steerage of more efficient care. It also could mean looking at what's included in the administrative service agreements. Which is something that we've done and we're going to talk about today. There might be a couple of opportunities to pull some of the services from those administrative service agreements based on utilization and value. And so we'll spend some time talking about that. Making benefit changes is nobody's favorite option. Generally speaking, when costs are shifted onto employees, that is a negative thing. It's something that we all try hard to avoid. That said, there are some benefit changes that we've included in this deck, some of which you saw last month, some of which will be new for today. And so we'll walk through those and have a discussion on, if it makes sense to consider indexing some of those plan design components in 2026. And then the final bucket, using stabilization funds. We've talked about this one a lot. We'll talk about it a bunch more today. Being thoughtful and strategic with use of reserves is important for lots of reasons. And so we'll revisit that as well and make sure that everyone is understanding sort of the dynamic at play when those reserves are used. But that is something that we've included in the scenarios once we get there a little bit later on in this deck. So with that said, I think we're ready to shift, and I'm going to pass it over to Emery to give us an update on where we stand with regards to the 2026 financials.
Thank you, Andrew. So we'll go through the medical, dental, and vision plans on this page. There are some others, fully insured like benefits on the next page. But taking a look at the numbers here, you can see the different plans there on the left, the type of coverage they are in the second column, and then the admin fee change from 25 to 26. You can see that for Providence, statewide choice, the admin fees, round three admin fees are essentially no change from last year. Going down, Kaiser's fully insured, so they had provided an overall package. MODA's admin fees actually end up being a little bit of a decrease from last year with some of the changes that essentially being recommended with nurse lines. Delta Dental of Oregon's about 1.9% increase in VSPs holding flat. So for Providence, this is going to be zero. This is a projected 0.0. We will talk quite a bit actually about some of the changes that's happening with Providence. So despite some of the changes, there is going to be right now no admin fee change for those changes. And then the column on the right, I think is probably what you're most interested in, which is the rate increase based on the latest data that we have. And while last month was bad news, this new month is a little bit better. So as Andrew did mention, the costs are a little bit lower. It's a little bit smaller, I guess, gap to the 3.4%. It's now back to 68.3 million. You'll see that on two of the next three slides, but it did drop about 10 million in total. Some of it was due to the updated census. So we did use the March census for the composite rate. But some of it was due to slightly better experience. So the February claims were not nearly as high as the January claims. And so overall cost did reduce by a few million in this case across the self-insured plans. So for Providence statewide, it's a 7.0% increase, and that is after accounting for the performance guarantee offset. So we did apply to those rates. Providence Choice came in at 11.1. I think it was closer to 12 before. Kaiser, their rate increase is 6.9 for medical. It's the same as last month. They took a look at experience, and the experience was actually worse. So this 6.9 does reflect essentially a concession to hold the rates at where they were for round two. So there is a little bit of rate concession coming from Kaiser in this case. For MODA Medical, it's at 12.9. So that's actually pretty close to where they were for round two. MODA Dental did drop a little bit to 3.2%. Kaiser Dental, again, the underlying costs were higher. They projected out a higher rate increase. I think the utilization for Kaiser Dental has definitely come back compared to prior years, and that does result in a bigger increase than I think the 9.2, but they did provide a rate concession and a rate hold to round two in this case. So it's at 9.2 again. Willamette is at 7.9, and VSP did drop just a tenth of a point to 0.2%. So overall, again, the experience a little bit better. The total projected premium is slightly lower at just under $1.5 billion. Next slide. So we have the SI Flex and VHS, Benefit Health Solutions. Those are unchanged from last month, so it's still 0.0. And then Weight Watchers, the rate is minus 12%, and that's about 1.4 million total. About 2 million total for these three benefits. And again, as mentioned before, currently 68.3 million above the 3.4% limitation. That's kind of like an important number as we go through some of the scenarios and the plan design changes and using of reserves in this case. Any questions before we move on to the next slide? Okay, so this is one slide that is going to be pretty important, at least conceptually, for the discussions today on the medical. So in prior, as in with prior years, some of the plans are not meeting that threshold for essentially a low-cost plan, the 10% differential from statewide. So Hazard deductible is still currently fine. Depending on some of the plan design changes that might come into question especially if you start making some pretty big plan design changes on statewide. But right now they are 11.3 below statewide, and so they will remain a 1% plan. And they are currently the lowest cost plan for the OUS, for the Oregon University System employees. So that's actually kind of same as 2025. So that's not really a change in this case. But MODA and Choice, both are still not meeting that 10% delta between that and statewide. MODA's at -5% below, and Providence Choice is at 6.5% below. Those gaps are bigger than they were last year. Last year, you decided to buy down the rates to hold them at low cost plan status, and so that members would be able to pay the 1% contribution rather than the 5% contribution. That is one of the possibilities that's being proposed today, and we've discussed this, I think, in prior meetings. Essentially, $31 million in reserves is needed to buy down to get to that 10% threshold. So reductions, if you do buy down reserves, essentially using reserves, it does make the delta, the gap, lower because you are not asking the agencies and the states to fund that gap. You are using money from the stabilization fund. $31 million is currently your stabilization fund that's unreserved after IBNR and other things. It's a little bit above 300 million. We do show some slides later where it's right now, if you didn't make any plan design changes, I think it's about a little over 200 million. That is below your current target, which is 300 million. And we can talk about that when we get to the scenarios. But the reason we have a target is in case costs go way up. And we'll talk a little bit about this on I think the next slide, potential reasons for, just making sure that you're able to pay the claims. But you currently do have more than, I think, what we would say is necessary for a year or potentially two. So buying down buying down for the low cost plans would not put that in jeopardy, but it is $31 million. So any questions before we move on? Okay, so this is the composite rate comparison over time. Down, I think the real changes are in the final two rows. So we do have the 2025 final, which on the left is what was the composite rate as of the renewal. And so you did meet the 3.4% with all the changes, the buy downs, and actually a very, very small funding assessment adjustment to be the 3.4%. On the right, that's the composite rate after applying the March 25 census. So taking a look at that, with the census, there has been a little bit of a shift again towards lower cost plans. And so that's part of the reason why the deficit or the gap between that and 3.4 is lower. It's 2.8%, so about 0.6% lower cost as a result of members shifting to lower cost plans in this case. So that did help out. It's been a continual process over the years, and you can see how every year the updated census shows that it's lower than what you ended up in the renewal as people keep moving to lower cost plans. So that does help in this case. Yes.
Just to underscore that, because we used reserves last time around to continue to have the 1% plans, we have continued to see a migration, and over time, that does save money.
Yes, it does.
And it saves the agencies money too.
Yeah, I think the column on the left, that's what the state, can't speak for universities, but they set the composite rate when they do the budget development baseline at that 3.4%. Column on the left, when it comes in below, see the snapshot taken into the actual plan year of what members have hold, and it's lower than 3.4%. So that doesn't mean every agency is lower or it's consistent like that, but definitely on an average across the whole state, it is lower than 3.4%.
The agencies do essentially win, I guess, a little bit as the membership because their outflows are lower than.
And overall, we all get
Yes, and
going into those more managed.
Yeah.
Right.
So the round three, I think we mentioned 8.38, or 8.4% rounded. So that's about just under $2,000 per employee per month. 1989.56 is the current composite rate in this case. All right, next slide. So we, in terms of the projections, we are using essentially the same trend rates for the projections that we have talked about in the past, and it's the same as last year. As we start talking about using reserves, the issue with reserves is to protect against underwriting risk. So underwriting risk can consist of basically random fluctuations where you have some larger claims or just members use more services for whatever reason. So that is part of it. Another part of it is just essentially if the trend rates that we use in the projections are wrong. And, there can be various reasons for it. Sometimes there's just, during COVID, no one was able to use services. And so that went down, that ended up creating a big surplus and it was a win. But there are, I guess, some concerns that the current economic condition and the current situation with the tariffs would potentially result in higher costs. And so as we talk about using reserves, this is something that has to be kept in mind, that we are using essentially 6.5 for medical and 10 for pharmacy, but those underlying costs could change or could increase based on essentially multiple factors here. So, the cost of the goods, a lot of the medical supplies, a lot of the pharmacy, the ingredients come from overseas. And if there's going to be tariffs on those will obviously come through and end up getting passed through as part of the cost. And so there's some protection on some of this, contracting gets set usually over a longer term schedule. So for certain types of devices, certain types of fees, there's a fee that's set. But that's not in all cases. So pharmacy might move a little bit quicker in terms of the impacts. There's a facility, you're capped at 200% of Medicare, but what that Medicare pays could change from year to year. And in a couple of years ago, I think it was 4.1% for the unit costs, something like that for a hospital, depending on the underlying conditions, the wage index, the costs, of goods, that could be much higher. That could be higher, definitely higher, and that would be essentially since how the contracts are set, 200% of Medicare, that would directly impact your the payments out.
I just have a question about that. So it's the DRG hospitals that are impacted by that, right? And there's a lot of care that happens outside of hospitals too, that we potentially get charged more than 200% of Medicare. I mean, we're already paying up to double Medicare rates as PEBB in a lot of situations. And we don't have any controls right now for other like clinics or specialists or other caps, right?
There isn't a hard cap, but we do rely on the plans, and we are vetting. We do vet the plans. We take a look at what their contracted rates are to make sure that they're competitive. And we've been doing that. We have a presentation for IWG that will show some of that. Compared to free plans, and we do. That's part of what we ask and rely on the plans to do. And with the RFP, that's going to be a big part of it.
Sure.
So there is some vetting, but yeah, there isn't a hard cap on that. So depending on how contracting happens. And, I think with dental, it's kind of happened a couple of years ago where post-COVID, the dental underlying contracted rates did go up more than what has been historically in terms of the underlying trends. And so that did show up in some of the dental increases, I think last year and the year before. But you would probably, yeah, there isn't a cap. There's probably going to be some potentially higher increases for more protracted, prolonged negotiations with facilities and doctors groups as they look to get higher reimbursements to offset their costs.
But the carriers control that.
They are negotiating that. I don't know how much they control. Some providers are owned by the underlying plans, so there is definitely some control there. And we do scrutinize that, but it's not all of them are, you know, at that level of control. So there is a potential chance that, you know, some provider groups, you know, could say, hey, you know, we need to pay more for nurses, we need to pay more for just inflation and all the other services that we have. And so we need higher rate increases for next year. And that's for 2 years down the line, whatnot. So those are the things that we're watching out for.
So just since we're on the catastrophizing slide, can you remind me, like, some of the agencies are, you know, like 97% funded by federal funds. So can you just remind me what happens to our finances if there are layoffs?
I would, I guess I'll turn to Ali to help out with that question.
Yeah, I mean, we're measured on 3.4% per employee per month. So, you know, I guess there's a workforce contraction that would still apply.
So,
Yeah.
but as far as our reserve though, I guess it wouldn't affect us one way or the other because it's just like per employee per month. That's how it works. But like if we projected a certain number of employees and then that number ends up being less by the end of the year, let's say.
Yeah, so that is because it is on per employee, that's not going to be impactful. But I think the bottom right-hand column is where I would probably worry the most. So job security, income and job security can cause, you know, if it's not there, people will use their services, especially if they know they're going to be losing their jobs because their medical coverage is going away.
Yeah.
And also just additional needs. I think the stress of COVID result in really high behavioral health needs. Losing your job and the current situation in America might cause behavioral health needs. I mean, that's one of the things that I've heard that, you know, it's definitely the need is growing. And so those sorts of things would impact underlying utilization. So the worry for me is, yes, your number of employees goes down, but the cost per employee is going to go up. And depending on who gets laid off or loses their jobs, if they are newer, younger employees, the older employees staying on, older members staying on will result in higher costs as well. So that is a concern that needs to be taken into account as we talk about using reserves. So this is just something to kind of keep in mind as we talk about this, you know, with our overall medical 7% trend. I mean, could it be higher? Yes. We have historically gotten medical trend in the low to mid double digits, you know, so that's not that long ago. Some of us may remember those times where we were using 12% trend, 13% trend. And not going to say it's not going to happen. I'm not going to say it is going to happen, but you know, it could. I am a little, at least in the short term, a little bit worried that potentially we could be seeing higher trends than what we currently have. We did not account for this in the rating. You know, it would be a really big hit, and you probably potentially want to use reserves to offset that. That's what it's for, right? That's what the reserves are there for, to potentially offset really high unexpected costs. And so, in lieu of making really big plan design changes, it's like kind of like just be conservative on this and just assume there's, you know, make sure there's enough in the reserves to offset any potential large fluctuations in costs for now. But we will talk about that longer term plan. So that was very happy. But any comments, thoughts before we move on to I guess the lighter topics of dental vision?
So if I understand the analysis correctly, the primary direct impact that we can expect from tariffs is the increase in facilities costs that reflect the supplies and other expenses which are often imported.
That, you know, this is where it gets a little, that's where the facilities will see the biggest impacts. depending on the contracting, you might not see it until next year or the year after. So there may be a little bit of a delayed impact there. Facilities may start asking for more money, and you might see bigger negotiations on those who are like coming up for renewal. But that's one of the biggest impacts, it is, but wages too. I mean, as inflation goes up, people want to get paid more and wages are 60%. And so that will impact, and there is the wage index that's tied to percent of Medicare as well. For some of the, there's contracts on some of the non-DRG facilities, but a lot of those rural facilities do get paid, for Medicare and Medicaid based on cost basis. So those costs would go up as Medicaid gets cut. The impacts of that on the commercial rates and their health of the facilities is going to be a big question. And so that might have some other direct or indirect impacts on the rates that commercials can get.
I'll update my takeaway to the most obvious direct impact might be there, but it's complicated.
Yes.
And potentially more than we're able to get our heads around.
And with the tariff situation, I mean, they've been declared, but they're not necessarily been really, I mean, they change. Because,
Right.
yeah, exactly.
Yeah.
Knowing exactly what the current situation is, who knows? So,
Uncertainty,
yeah,
got it.
very, very much uncertain. So that's, actuaries are risk managers, and there's a lot of risk out there right now. And
Thank you.
other questions, comments? Then I'll turn it back over to you.
Okay, all right. So with these next few sections, we're going to go through dental, vision, and then some of the supplemental renewals as well. So we'll start with dental. Can you go to the next slide, please? So these are the three dental carrier partners. Delta Dental, self-insured. Kaiser and Willamette Dental Group are both fully insured. And so I'll start with Delta and make some comments, and then I'll pause and get folks' reactions and questions. And so the administrative fee increase being proposed is a little bit under 2%. The gross cost increase, which is the premium equivalent rate, is going up 3.2% in 2026. And so there are some optional plan design changes that are being proposed that I can run through. The first of which is around adding sinus lifts and bone grafting for dental implants. And so sinus lifts essentially ensure that there's adequate space for an implant to be put in. And bone grafting is where bone is added to the jaw so that there's adequate support for the implants. This is one that came up through some member feedback. The cost impact is negligible. The next one is around non-IV conscious sedation for members who have intellectual and developmental disabilities. That was a big focus for us last year. And so this is sort of a follow-on to some of the changes that the board approved last year for members with intellectual and developmental disabilities. Cost impact for that one is also negligible. And then the third proposed change is around the frequency for x-rays. And so during the year, it was uncovered that there was a discrepancy between the handbook and how the plan was being administered, which sort of surfaced this particular issue. And so the proposed change here is to move the x-ray benefit from twice per year to one time per year. One time per year is Delta standard. It's also the ADA standard of care. And so we do think that one makes sense. You can see there's a slight reduction in the premium equivalents associated with that one. So there are some slight savings to move from 2 x-rays to 1. But taken all together, we are recommending all 3 of these. You can see it's mostly cost neutral, but again, the 3.2% status quo gross cost increase goes down to 3.1% with these 3 changes. And so let me pause there and see what questions board members have. If any.
Do we know, so on the x-rays, which the dentist because I broke a tooth and they had to do an additional x-ray, is that one X-ray just because I go in and they want to take a look, or is that one X-ray no matter what I do throughout the year? Is that something that you know?
Looking over at Emily to see if she can answer that.
I don't know, I'm sorry.
Oh, okay.
No, it's,
No worries.
you know, if I accidentally break a tooth twice a year and I have to go in and pay X amount for, that might impact our members of bed. So it's just a
It's
question.
just one X-ray. It's changing it to one X-ray per year.
Yeah.
Yeah.
So I don't know the extent to which there's exceptions for situations like you described. We can find out.
Because I just had it this week, something I thought about.
I'm sorry that happened to you, but we can certainly
Yeah.
find out.
I-
Just preventive.
Yeah.
Okay.
Yeah, that's what I was
For
thinking.
Delta Dental, it's based on, the second X-ray is just based on the dentist assessment of the patient's oral health to get it.
So it could potentially be covered. So there you go. Okay, so
Yeah, that's fine.
yeah, cool. Good question.
Want a second X-ray, break your teeth, I guess.
Right. Hey, you're gonna bring it to you for a second one.
Yeah.
It's not worth it.
No.
But the frame of that means that it goes to one as the standard screening and then additional imaging or
Could be covered.
other things as indicated, depending on acute need.
So right now, if they have one X-ray, but then if based on the dental assessment, they could get an additional. With this change, they would no longer be able to get the additional X-ray. Yeah, correct.
So I'll move on to Kaiser, let you sort of noodle on those proposed changes on Delta while I go to the next proposed renewal. So Kaiser's status quo rate increase being proposed is 9.2%. We did review the underwriting methodology, and there has been a not insignificant increase in utilization on the plan. And so that's not necessarily a bad thing. So Kaiser has had some outreach campaigns that have been underway, as well as they've successfully backfilled some open positions, specifically around dental hygienists. And so that has improved access essentially. But it does mean there has been higher utilization than we've seen in the last couple of years. So a little bit higher than normal renewal on that one. There are some optional plan design changes as well. The first two around adding a deductible and removing the $5 office visit charges. Those would bring parity between Kaiser and Delta. However, the third one, the enhanced ortho benefit, would not be in parity with Delta, and that is obviously an enhancement. And so the first two are cost savings to the plan and additional cost for the members, and then the opposite is true of the third. This would be an enhancement for members and additional cost to the plan. And so taken all together, you can see what that means to the 9.2% increase, and a little bit of a different impact depending on the full-time plan design versus the part-time plan design. And so generally speaking, other than Delta, so for Kaiser and Willamette, we're not recommending that the board approve these optional plan design changes for a couple of reasons. The first of which is that we have gotten member feedback around the benefit maximums associated with these plans. And so that's really more of a Delta and a Kaiser plan design feature, and not really Willamette. But it has been a while since those benefit maximums have been indexed. This is probably a difficult year to do that. There would be costs associated with that, right? And we're trying to solve for excess costs. But nonetheless, given that members are asking for that change to the benefit maximum, it probably wouldn't be very well perceived for members to see that these additional costs are being foisted on them essentially through these plan design changes. The other comment is that, you know, when we're trying to solve for almost $70 million, one approach could be to look at making lots of small plan design changes across lots of different benefits, medical, dental, vision, et cetera. That's not really the direction that we're going to propose when we get to the scenarios. Part of the reason for that is that you make these plan design changes, you are reducing the cost, but you're not making a significant improvement in that financial position with regards to solving for the $70 million. And so that's one of those things where you can kind of make an argument either way. Do you do a couple of small changes that are more impactful from a savings perspective? Or do you sort of spread them out and do more small changes, including some of these dental changes. So let me pause there and see if folks have a reaction.
I do have a reaction to that, and I mean, I do appreciate like that we need to look at moving the dial and some of the, larger changes that we can make, and I know we have some of them on the table. I also just wanted to make a comment around Kaiser though, because I know that we had heard that folks were really having a hard time getting into dental because there weren't enough hygienists and so forth, for whatever reasons. And so for me, it rubs the wrong way to say, now you have to see a 9.2% increase just because people are getting the service they should have been getting all along. So I just want to name that.
Do you, the remove the $5 office visit charges? That would be an increase in cost for us, yeah?
It would be, yeah.
So
Yeah,
it's really
you're
only
right.
the first
spoke. You're right. Yeah, you're right, Sean. Yeah, so the way that benefit stands today is it's a $5 office visit copay plus co-insurance. And so the co-insurance would still be in place for those members, but you're right, that's an additional cost. Thank you. Okay, and then with Willamette Dental on the right, this is again a fully insured funding arrangement. The status quo increase without any changes to the plan design is 7.9%. Sort of a similar story around utilization being driven through better access. And so over the last, call it 2 years, we've been talking about some access issues around Willamette Dental specific to certain markets within the state where we knew that they were having staffing challenges. And so several of those staffing challenges have been resolved, which is great. And so just looking to make sure I don't misspeak on which offices. So the Springfield and Eugene offices are now fully staffed, as well as the Albany and Corvallis offices. And so they have successfully worked through the wait list for 2 out of the 4 of those offices. There are still a couple of problem areas, specifically around Medford and Grants Pass. So there is more work to be done with regards to backfilling some of those positions, making sure that members do have access to the benefit. But there have been some promising improvements around hiring additional dental hygienists and dentists in those offices that have struggled for the last 2 or so years.
So I would say my same comments for Willamette. That's for Kaiser. People should be getting this.
That was just something else. I was told just this last week that Kennewick as well is down at least 1 dentist.
Oh, okay.
Because it's over 2 months to get a cleaning now there.
There are some optional plan design changes here as well.
Emily.
Oh, sorry.
I have a question.
Rich,
Oh, yes.
Emily?
Yeah, I actually have a general question, a public health related dental question. I'm just curious as to like fluoride in the water, for example.
Emily, I think
What's that?
sorry, we lost your audio for a second, but I think you're back.
Oh, okay. Yeah. So, I don't know like what the current state is of fluoride in the water across all
Losing
36
you.
counties. Oh, can you hear me?
You're breaking up.
You're
Emily.
breaking.
I want to.
Oh, okay. Maybe I'll just follow up when I get there. I'll
Yeah, that
try.
works, Emily. When you're,
What's that?
sorry, you'd cut off for a second, so I thought I had an opportunity to jump in, but we can, when you're here, we can certainly circle back to this and take your question live at that time if that works.
Okay. All right. Thanks.
Still. Okay, all right, thank you. Yeah, I just want to call out Linda's comment that Grants Pass is an area that still has a staffing shortage. Grants Pass, Medford, and it sounds like Kennewick as well.
I guess it's Richland, but Kennewick, Richland.
Richland, okay.
There's like a line.
Emily, I see that your hand is up again. Can you hear us? Let's go ahead and defer your questions until you have better signal.
Yeah, sorry, I was trying to put my hand down. So,
All right. We'll look forward to seeing you pretty soon, Emily. Drive safely.
So there are a couple of options around plan design for Willamette as well that are intended to reduce the proposed increase. And so there's two options, but the cost impact is actually equivalent between the two options. And so the first is around increasing the office visit copay from 10 to 20 and changing the routine extraction benefit 0 to 20. Option 2 doesn't go as far with the increase on office visit copays. You can see it goes from 10 to 15. But we've got additional changes as well around fillings, root planing, the routine extraction, which is similar to option 1, and surgical extraction. So, similar to my prior comments, we're not necessarily recommending these changes. However, there could be an argument to do them. And so I'll pause and see if board members have any other comments or questions around those and the general approach and recommendation.
This looks quite a lot like cost shifting
Mm-hmm.
and putting the costs on the members.
So we weren't sure if you wanted to vote on dental, vision, and supplemental in this meeting or not. And so I guess Dawn and Siobhan will look to you. And if you want to continue for now and think about it, that works too. If you feel like you need the full picture.
Emily has questions and, we have gotten late concessions before, so.
Yeah, I agree. I mean, I'm still thinking about like fewer, bigger changes versus many smaller changes and so on. It's just not, I'd rather wait until we have kind of like the full picture and are sort of like sitting on that digestion and then move back to the whole picture.
Okay. All right. So let's move forward and talk about vision. This is a self-insured plan with BSP. It is in year 4, 2026 will be year 4 of a 4-year administrative fee guarantee. And so you can see that lightish blue row there at the top indicates that. So it's $1.15 is the administrative fee per employee per month. That is unchanged in 2026. The dark blue bar just above that is the gross cost projection. So again, these are the monthly rates, premium equivalent rates. And so based on the claims experience, there's just a slight proposed rate increase there of 0.2%, which amounts to $27,000. There's an optional plan design change here that we've talked about a little bit over the years. It's around retinal screenings, which are it's a procedure that's advanced imaging for the inside of the eye, and it prevents the need to have your eyes dilated. You go into the office for a vision office visit. And so this proposed change would make it a richer benefit for members enrolled in the base plan. And so today, for members in the base plan who want retinal screening, they'll have to pay $39. This would change that cost share to $10. There's also a bio plan, the plus plan, that's not shown here, but that plan design already has a $10 copay for the retinal screenings. And so given the state of the projected finances for 2026, we're not sure that this one makes sense for 2026. That enhancement would add $267,000 to the plan in 2026, so we are not ready.
So the slide says accept the status quo.
Yeah, sorry, confusing. Yeah, so status quo, said another way, decline optional. Yep.
This or that.
Good call out, because I think that same issue is going to show up in the deck. So I'll try to make that clear as we're going. We are recommending declining this optional plan design change, which would make it a less of a cost share for members for retinal screening. Those members do have access to the retinal screening today, would just mean less out of pocket.
Yeah, I like that. No matter which one you check, you don't do it. That's great. That's
And you
interesting.
take the recommendation.
One thing to throw out, I did find out this year that at least my doctor, I don't know how many in the plan would, but my doctor now is requiring everyone to have a retinal screen. So it's something we might want to look into, because if they're requiring our individuals on our base plan to do that, it's additional money out of their pocket that they're gonna have to pay or find a new doctor. Now, that's what I got from the front desk. So I'm, but that's what she was saying, that, because I asked about, the screening, and she says, oh, yes, you have to do it. I asked, she goes, yeah, it's required, so.
Yeah, we can certainly get some more information from that and probably reach out to our partners at VSP to get their take on, are they hearing that from a lot of providers? And does that change the equation?
Yes, does that
Yeah.
change where we go here? So, thank you.
I guess, Andrew, I just wanted to add, that Health Equity Committee did review all of these changes. So, we've had discussion, and obviously, as Don said, the cost shipping, those were a negative, and obviously then an additional benefit. Where the board is at this year with making decisions. So, but we did do that work and had our discussions.
I understand things.
Thanks for that input.
Right, so let's move forward to the supplemental renewals, and we'll start with ASI, oh, no, sorry, I'm jumping ahead of myself. We're gonna start with Weight Watchers. And so there's a couple of things to talk about here. So where I will start is around the renewal and some successful negotiations we've had with Weight Watchers. The first of which I'll call out is that we did negotiate a reduction in their annual program fee cap. And so in 2025, that's 1.567 million. We negotiated a 12% reduction in 2026 to 1.379 million. We also worked with Weight Watchers to simplify the fee structure, which you can see on the left, starting at $48 and then working your way down depending on what month an individual member is in with their engagement with the solution. It varies. And so the go forward pricing would be $32 per engaged member per month. And that would include the Bluetooth connected scale. We also had a couple of changes and improvements around how engagement is being defined, as well as some enhancements on the performance guarantees with more fees at risk, and continuing to really look at outcomes, which for Weight Watchers, is weight loss. And so structuring the performance guarantees in that way to achieve clinical outcomes is the intent there. So that's the first part of the discussion. The second part, and I don't know if folks have seen this in the news. I think I just hit the news last week. Weight Watchers is likely going to be filing for bankruptcy. And so they have had some financial difficulties recently, and those difficulties continued and intensified with GLP-1s entering the market. And so it appears that the type of bankruptcy that they will be filing will be Chapter 11. So what that means is it would be a debt restructuring, but their operations would continue. And so given that, we are recommending that the board renew with Weight Watchers. However, we have reached out to the carrier partners who own the contract. This is a subcontracted solution. And so Weight Watchers contracts with Kaiser, with Moda, with Providence Health Plan. And so we've asked those three carrier partners to take a close look at the contract and propose any changes that might be needed to safeguard given the uncertainty around bankruptcy. The other comment I'll make around that is that PEBB pays based on engagement throughout the year. And so that's a safeguard that's in place already today, right? You're not front loading the payment and paying for $1.3 million at the beginning of the year. PEBB pays as engagement happens throughout the year. Obviously, none of us would want operations to discontinue mid-year. It doesn't appear that that is what would happen. However, this is very new news of this. There are still some questions around what this is going to mean, Weight Watchers and for PEB. But it's an important development that is sort of unfolding. And so I will pause there and get folks' reactions. Were people aware of this, or, you know, guessing not, you know, but this is sort of hot off the press, so.
So I'll just mention this isn't really the time to get into the details of it. But I just say in those conversations about restructuring the contracts, you know, theoretically, the idea of going through chapter 11 is that an organization has an opportunity to sort of like reinvent itself for the new, whatever the reason was that they were going into bankruptcy. And so just encouraging the plans really, and you all in those discussions, that we've talked about this several times. Now that GLP-1s are on the market, like it really feels like this is a time that we need to rethink what we're doing around weight management. If they end up coming out of bankruptcy and then their plan is basically what we were doing before, but kind of less, to just try to like have lower costs, so just like do more with that kind of strategy. I mean, that's just that will likely not have the results that we want to have. Because GLP-1s are so incredibly expensive and probably inevitable at some point. There's some room for investments around like, you know, prescribed, food, you know, personal trainers, like all these sorts of things that have been very just like, oh, it's administratively, it's just too hard because who would do that? How would we check, you know, like all these excuses. And it's just like, look, if you're looking at the difference between paying someone's prescription for like $5,000 a month or whatever, that gives you a lot of room in comparison to do some things that are like totally impossible. So it's just, I don't know. I'm just saying, like, since they're already in a tailspin and sort of figuring out, I guess I would just encourage some like pushing on them. Because it's like, if their plan is just, they're gonna do what they were doing before, but just kind of like less people on, you know, available. I don't know how interesting that's gonna be for how long, right? I mean, if they need to come to something, come forward with a new idea in this new environment. That's what it's. But anyway, that's a different discussion for a different day.
That said, unless and until GLP-1s are being covered and more widely available or have members, and it's something that, of course, we will be tracking and continuing to try to resolve. It's really important that we provide options, especially evidence-based options, to support weight management in our members. And the turbulence related to that announcement then is something that we're going to need to continue to tune into as we hope to continue to support our members with weight management options unless and until GLP-1s come.
I would say even more so. Like as they come on board, like we really need some kind of partner that has a plan. Sort of beyond what we're doing now, but at least what they're doing now, yeah. My concern is that they just sign on a new contract and just be like, yeah, we're gonna do the thing, but it's kind of like less effective. You know, which is what you do when you come out of bankruptcy.
Fair enough. Thanks.
There is a potential option to revisit cardiometabolic strategy in CEOW this summer. So CEOW does, you know, focuses in on specific topics for deep dive research analysis in the summer. And so this could be one that's looked at. Obviously, that doesn't help with the time frame to either decide to renew or not, right? Because that decision will come in May. However, I think between now and the board meeting next month, we can get more information from Weight Watchers on what does future state look like and what is the plan, what's the strategy to make the business viable? And is it cutting cost or is it focusing on something new?
Yeah, one of the things for me is, I know it says that inactive for 1 month. So, I started a weight loss plan, right, which I did. I got the scale. I was in the app and did very well for, as we all do, the first 2-3 months. I haven't opened the app in 7 months, but I continue to weigh myself because it's the only scale I have in my house. Is just weighing myself and that sending it to the app considered me still being active in Weight Watchers and we're being charged for that?
So I'm glad that you brought that up. That is something that we have been having discussions with Weight Watchers on.
Right.
They want that to be considered engagement.
Okay.
However, there was a call yesterday that with Weight Watchers that I wasn't on because I was traveling down here. So I don't know how that conversation went, but that is something that we are, yes, Margaret, please.
Andrew and members of the board. So John Kessler from Mercer and I spoke with Weight Watchers yesterday on this exact topic, and we are still negotiating. They are due to provide us with some data that we requested related to this specific issue.
It's the only scale I have in the house, so it's the one I continue to use for the last 8 months.
Yeah, and
I
I noted to them that scales are a tool that have been in existence for many, many years. And that simply stepping on a scale isn't the same as engaging in a program. So we are waiting for some follow-up data and expect to have that from them pretty soon so that we can close this out.
Yeah, that's good.
Perfect.
Thank you. Super relevant question. Thank you, Margaret.
Emily, it looks like your hand is up. How's our connection?
Yeah, I don't know. Can you guys hear me?
Give it a try.
Not really. I was just gonna say that I actually use Weight Watchers and I go to the in-person sessions on Sunday mornings. And there's so many changes that are good with the app that people may not realize if they haven't been engaging with Weight Watchers lately. So I just wanted to just add,
We're losing you again.
and then you can't hear me?
We're still losing you.
Okay, I'll just wait till I get there.
Thanks, Emily. We'll see you pretty soon. Safe driving.
So,
Kimberly, it looks like you have your hand up.
Okay, so you guys can hear me? Can you all hear me?
yeah.
Oh, okay, good, thank you. So the same will be with,
Issue with the room audio.
yes, because I can hear
But
Emily.
if you mute your, if you mute the room, sometimes it will allow them to talk without any cutting. I don't know, it's just something that we can try.
Well, there.
We had that last time in our bargaining session. We had to mute the room every time somebody.
Okay, let's try again. You don't have to answer. Okay, so with Omada, it'll be the same thing. The scale is connected to Omada. So if somebody stops doing the counseling and the training with Omada, and still uses the scale, Margaret, that might be the same conversation that you'll need to have with Omada like Weight Watcher. That's all I have.
Good. Yes.
Thank you, Kimberly.
Thank you, Kimberly.
So this one will be on the agenda for May, and so we will get some additional information, continue talking about Weight Watchers and go forward strategy. So let's move forward. Two more vendors in this supplemental renewal subsection. The first is ASI Flex. This is your partner who administers your spending accounts and your commuter accounts. So the healthcare FSA, the dependent care FSA, as well as the commuter account. These fees are being proposed to be held flat in 2026. So no Benefit Health Solutions is your partner who administers COBRA as well as retiree premium administration. And similarly, no increase is being proposed associated with administering those benefits. Any questions on either of these? Okay. So I'm going to shift gears and talk about medical, but I'm wondering, let's see, what time are we scheduled for? Right.
11, so we still have a little bit of time. We can go through this next session.
Do this section and then we will see what time we're at. And so, could you advance, please? So this is a new topic that we have not talked about yet. This is a new partnership between Providence Health Plan and Collective Health, which is an organization that is a third-party administrator, TPA. This new partnership was made public 2 weeks ago. And so we have been spending a lot of time with Providence over the last 2 weeks to understand what this means for PEBB. And so I'll make a couple of comments here before we get a little bit more specific, but with regards to what this means. And so Providence has entered into this partnership with Collective Health to administer Providence's entire self-insured book of business. And so a little bit about Collective Health. They are a tech-forward TPA. I guess that's what I will call them. I don't know if that's what they call themselves, but they are a third-party administrator. They're headquartered in San Francisco. The organization has been in operations for a little bit over 10 years. They've got currently a little bit over 600,000 members nationwide. And so with regards to when this would impact PEBB, it would impact the Providence enrolled PEBB members as of January 1st, 2026. And a little bit about the why, in having some discussions with Providence, this is really about them wanting to grow their market share across the West. And thinking about how best to do that. And so in their internal analysis, they determined the best way to do that was to partner with an existing sort of tech-forward, member-focused TPA and partner with them on a go-forward basis, again, for their entire self-insured book of business. So this is not a PEBB decision. This is a Providence business decision in terms of how they are going to be servicing their self-insured plans. Little caveat there at the bottom that we've included, when we've had our conversations with Providence to start to understand what this means for PEBB, we ask that they really keep the conversation to what it means in 2026, not talk about any sort of future enhancements that could be on the table of 2027 beyond. Given the RFP that is underway, we thought it was important to sort of set up that guardrail and focus in on what does this mean in 2026. 2027 and beyond, across all bidders, that will be evaluated in the RFP. So let's jump to the next slide, which I think will start to answer that question. And so some of the services that Providence Health Plan is doing for PEBB today will remain with Providence Health Plan. Some will be done by Collective Health and some will be sort of a joint effort. And so we're going to show you this visual, and then we're going to, on the next slide, we'll get even more specific. And so I guess I'd call your attention to really the right side of this visual here. And so this is attempting to sort of show in a visual format what is the member experience with regards to this new partnership. And so Collective Health will be administering claims, and we'll talk about that on the next slide. But they also will be handling most of the member experience. So in 2026, Providence Health Plan members will be reaching out to Collective Health whenever they have a need through the health plan. It's being co-branded, and so it's being co-branded with Providence Health Plan powered by Collective Health. And so from the members' perspective, they don't necessarily think I'm going to Collective Health. They're going to Providence Health Plan powered by Collective Health. And so Collective Health's model in terms of their member-facing engagement model is based on care navigation. And so whether members are reaching out via the app that will be available or calling in and speaking with a care navigator or going onto the site. The intent is to provide care navigation for those folks. And so someone to sort of hold your hand as you attempt to navigate whatever healthcare issue you're trying to navigate, whether that's resolving a bill or finding a specialist or speaking with a pharmacist about a drug you've been prescribed. And so the goal there is to, provide a better member experience so that they have someone to help them navigate what we know is too complicated of a landscape. Provide better member outcomes, better member health outcomes, provide cost savings both for the member and for the plan through more efficient delivery of care. And so those are the things that this model attempts to produce. Yes, questions?
Yeah, so my understanding, so please correct me if I'm wrong, like right now, there's not an app for people for Providence and people call in if they need support. And so in this new model, folks who are used to calling in, will they still be able to call in the whole number and then get the care navigator? Will it be pretty seamless? Or will there be some disruption there that people have to get used to calling a number and so forth?
So I think there is a new phone number, and I see Cash nodding. And so members will get a new ID card. It will have the new phone number. It will have the co-branded logo. And so there will be that. Members will have the app available for the first time. They will have a new phone number. I don't know, Cash, if I can put you on the spot, what happens if someone calls the old phone number in 2026?
Yeah, great question. Right now, we're working through to ensure that if someone calls that old phone number, they get ported over to the new phone number. So, but this will allow PEB members or any of our self-funded groups, not just PEB, to have a dedicated phone number that's specific to them. But our existing phone number right now through the algorithm that gets them to the right team today would just direct them to the new phone number team. So it kind of is the same logic.
The other important feature of the collective health platform is around point solutions. And so the existing point solutions that Providence Health Plan currently subcontracts for, things like Progeny for fertility or Omada prediabetes, and a number of others, will all be integrated into the collective health platform. And so the idea there is to more effectively drive engagement into those condition-specific solutions. There are a couple other things related to those point solutions, improved reporting and analytics, because those are fully integrated solutions into this platform. And so that seems promising as well. The next slide has a little bit more detail, but I want to pause before we move on. Yeah, Sean, I see you have a question.
So like care navigation, back office administration, dietitians, care coordination, member advocacy. This is what I assumed we were paying Providence for all along. No?
So this is it is a different flavor of care navigation. Care navigation does exist today. And so when Providence, and I'll turn it over to the Providence team in a second here in case I misspeak, but when Providence was considering how do they evolve their services to capture more market share across the West, they thought, well, do we build these enhancements? Same services, but an enhanced model, or do we partner with someone who has already built it?
So like, for our, just thinking about our cost for, administrative fees, which we've been paying for. So are they like, your understanding is that like they're shrinking their current workforce in order to bring on, or are they just like adding on, or like, how does that work into the future as far as absorbing our administrative costs in the future for services that we were?
Yeah.
already getting?
So I can tell you what I know, and then maybe Cash, you could jump in. And so the existing services will be sort of divvied up between the two organizations. There are, I believe, some discussions around the existing Providence Health Plan care navigators who are answering the phone. I believe you're exploring potentially having them continue to answer the phone under collective health. Let me know if I'm misspeaking on that. Am I right? Okay. And the administrative service fees that are being proposed for 2026 there's no increase for collective health, right? We're taking existing services that are being delivered today, and there'll be a different party doing some of those services, and we'll continue to get all of those same services.
For 2026.
Yeah, 2027 will be evaluated in the RFP. So I can't speak to what that could look like. Providence and Collective Health submit a bid, which I assume they will. That will be evaluated in the RFP. Okay. Did I misspeak on any of that? I don't want to.
No, you didn't. And to just get back to your point, Sean, the services that you pay Providence today, as Andrew alluded to, what we've talked about is ensuring that those are the same things you're getting. What this is intended to show is just how those things will be different slightly in the new world. But you're right. You're already paying us for all of those services. It's just going to be delivered in a different way. That's it. But we're still delivering those services, correct?
Let's jump to the next slide, which I think is going to fit with this conversation. And so this is our attempt to list out the services at a high level, the key services, I'll say. And you can see those functions being delivered today, all by Providence Health Plan, and you can see where those start to get divvied up between the two organizations once this new partnership goes live on 1/26. And so for those first few rows, the network, let's talk about that one. The network is unchanged for this arrangement, so there is no provider disruption. Providence continues to own network management, contracting with providers, credentialing, all the things that go into network management remain with Providence. From an operations perspective, and we're referring to like account management, contracting with PEBB, performance guarantees, those also will remain with Providence Health Plan. There will be some involvement from Collective Health account management as well. And so in hindsight, maybe that should have been split out and that could have showed sort of co-servicing specifically for account management. Pharmacy, this one also remains with Providence Health Plan, no change to the PBM or any of the financial terms or any of the utilization management levers on the pharmacy side. Those continue to be with Providence Health Plan. Utilization management will be co-serviced by both organizations, as will implementation and communication. More to say on that in the next slide, so I'll just sort of cruise through that one for now. Provider directory. So for members who are needing to search a provider directory, they will now be using the Collective Health platform to do that. Again, the provider network is unchanged, but the directory will be accessed through Collective Health, whether it's through the app or the site or speaking with the care coordinator. Point solutions, those will be integrated on the Collective Health platform. Claims processing. So when providers are submitting bills, they will be doing it to Collective Health, my understanding. And Collective Health will be processing, paying those claims, doing claims integrity processes. So that will all shift over to Collective Health. Care management will also go to Collective Health. And so this is an important function of any health plan. And so the ability of the health plan to identify special needs, high cost claimants, folks with complex conditions, conducting outreach to those folks, trying to engage with them and trying to influence their care journey so that they have better outcomes and less cost for the plan, all the good things that we try to achieve with care management, that will be going to Collective Health. From a member experience perspective, they will get new ID cards as of 1/1/26. They'll be engaging with the app and website through Collective Health, Point Solutions, and customer service also through Collective Health. Navigation, which we talked about today, is through Providence. That will be through Collective Health. If the board decides to continue with the HEM program and HRAs, which is something we're going to talk about a little bit later on today, that also would be integrated with Collective Health. And then the final row around reporting and analytics, that also will be provided by Collective Health. There's some enhancements related to the integration of those subcontracted point solution vendors that should hopefully allow us to do more interesting and complete analytics with regards to how those programs are performing. Pause. See what questions. Josh and broader Providence Collective Health team, anything big that I missed that you want to shine a light on? Do you think that was a fair overview in terms of how things are?
I just want to make clarifications on this slide. So
On the effective 1/1/26, there appears to be a lot of things that are shifting to collective health. But to clarify, most of those things are kind of co-owned. So as we think about like the health, or if you choose to continue him as an example, the health risk assessment still is owned by PHP. It's served up through the collective health member app instead of My Providence as an example. But we still own that. Reporting and analytics, there's the base reporting that's going to be available as Andrew alluded to. However, there are still performance guarantee type reporting that PHP will still be responsible for, that we still would handle. So there's kind of a split, even still on that side, between the things that PHP is still responsible for and collective is responsible for. So we still co-own this. And again, PHP owns the whole thing. So just wanted to add that point.
Not seeing any other questions. So let's jump to the next slide, which is an implementation timeline that Providence and Collective Health have provided to us. And so they are in the midst of migrating some of their other self-insured groups that renew mid-year. And so presumably there'll be some good learnings from those processes that can be applied to PEBB. Those three orange bars at the top are around proposed cadence for communications and how we educate members on what's coming, what can they expect, what does this mean for you. All of those communication pieces will be reviewed both by OHA staff as well as Mercer Communications consultants. And so that will be important and will be something that, together we'll start collaborating on to ensure that communication rollout is thoughtful and easy to understand, and try to get ahead of any members who are like, wait, hold on, what's happening? So those were the main points I wanted to hit on this timeline, with as opposed to sort of specific times that things will be happening. There's a lot of activity that's happening, that's continuing to happen, and will continue between now and 1/1. With regards to integration, but also member communication and education. So probably more to come on this topic over the next few months, but this is the sort of preliminary overview we wanted to provide you with, so that you start to understand what does this mean for PEBB? What does this mean for PEBB members?
So one aspect of this that we really haven't discussed is kind of like the financial impacts of this. With the ASOPs, those are remaining the same. There are some potential, let's just say, claims and essentially trend savings as a result of this collaboration. There's some information, in terms of increased, management of services, navigation savings as well. There's like a utilization management program that's being implemented that has promised. There's been some pretty big savings, like almost anticipated about $7 million in savings as a result of those programs. We did not include that in the rating process right now. It's kind of like, okay, it is big and bigger than what I think, there's a lot of savings there. And, if it does, it would really not impact the way PEBB or the board might consider using the renewals or the reserves, because it is kind of, while it's there, it's going to probably result in more reserves being used to buy down MODA and potentially Kaiser deductibles. So it's kind of like all one big pot in this case. But there are some anticipated potential savings as a result of this, which would help with the longer term situation in PEBB. But we can discuss that a little bit more if you like. But it's we're still kind of vetting this entire solution and result and impacts.
And you meant buying down Providence versus MODA, right?
What?
Oh, you said buying down.
No, sorry, Kaiser deductible and MODA potentially. So MODA would need to, so if we apply those savings for statewide and choice, which, because this would be kind of like covering both of those, it makes a gap delta between the 10% higher for MODA. And so then you would have to spend more reserves to buy down MODA. So in effect, you're using up some of that savings to just bring MODA down.
And right now we don't have to buy down Kaiser deductible.
You do not, although I think once you start talking about Garner and you start talking about, $7 million is like 1%. and they're at 11% delta. Once you start adding Garner, which is another percent, and then this another percent on top of that list potential other changes, then you would be talking about buying down. Gotcha, Doug.
Thanks, Emery. Any last words before we go to break from the board?
Do we want to get Emily's comments?
Oh, Emily, yes.
Oh, yeah. So for dental, I was just thinking of, like, from a public health perspective, I'm just not aware of what the current state is of fluoride in the water across all 36 counties. So I know, like, I think Beaverton has fluoride in the water, I believe, but I'm not. So I'm just thinking, just in terms of, we've got a new US Department of Health and Human Services head of Kennedy, and I know he's not for fluoride in the water. And so I'm just wanting to make sure that we're aware of where is there fluoride in the water in our state and right now, and then where isn't there fluoride in the water. And then I also remember Seattle did like this big study. It was years ago, pre-COVID, about dental needs, and looking like with an equity lens, and learned that Asian American communities have the worst dental health. This was in the Seattle area. But because Asian Americans are the fastest growing population in Oregon, and, you know, I just want to make sure that we're looking at those issues with an equity lens specific to Asian Americans.
We have to check public health and see what they have.
Okay, yeah. And then what was the other thing you wanted? Oh, Weight Watchers. So I'm a member of Weight Watchers and I love it. And I go in person, which I think is a different experience than if you're not going in person every week. So, and our Weight Watchers is at East Portland Community Center. So it's just this amazing thing every Sunday morning that I go to. And like every time there's like, I mean, there's all kinds of families and children and grandparents and piano playing and art projects and ping pong. And it's a really cool vibe. I don't know about the other Weight Watchers programs, you know, across the 36 counties, but ours is in East Portland Community Center. That's where I've met people. I met the vice president of Oregon Electric Vehicle Association. And every week he was like, I think you would qualify for these incentives to get this electric car. And he was right. Like, because I'm a single parent and a 3-generation household, I actually qualified for federal and state incentives. And now I have an electric vehicle, which that wasn't even on my radar, you know. But he's also a fellow union member. So I'm like wearing my SEIU shirt, you know, and then all kinds of people are like, oh, do you work for the state too? And he's an administrative judge, you know, and he's doing cases in Eastern Oregon. It's just a lot of social capital that can happen in person, not even just Weight Watchers, but other things. But Weight Watchers, they don't call themselves Weight Watchers anymore. They call themselves WW because they don't want the emphasis on weight, because they want the emphasis on changing behavior, and that's permanent. And they've got, like, I can show you guys in break, like the app I have. It's like, what vegetables do you have in your fridge? Put them in here. Here are 50 recipes that you can use, you know, with those vegetables that are in your fridge today. Or, you know, do you want a culturally specific group to connect with online? Well, here we have some Latino groups happening. You can go to the group in Australia, you know, like, it's just really cool. And I think a lot of people who aren't on the program today don't know. And I don't think they're good at talking about it either. So that's something I just wanted to add.
Thank you, Emily. Welcome. That concludes this segment of the meeting. Let's go ahead and take a break and meet back at 11:15. And I will note that I am being pulled into another meeting for the next little while. So Siobhan is going to cover the meeting for that period. I'll be back when it's finished. Thanks, everybody. Have a good break.
And I'm gonna hand it back to Mercer. Andrew's presenting on that, is that right?
Yeah, it's gonna be, yeah, Andrew's gonna take the lead on it. I don't know, hopefully he's gonna be, hopefully he'll be back in a minute.
Yep, as soon as Andrew appears, we will get going, everyone.
You had to go out and feed the parking.
We plug in the electric bulbs. Remember those?
I do remember, I do.
Parking machine.
I was in some town not terribly long ago where you had to take
Yes,
points
true.
into the meter. I don't remember where it was. It's surprising.
Get a break. 75 minutes.
Oh, it was in
Everybody
Pittsburgh.
go out further.
Pittsburgh. Okay.
Yeah, I was in Pittsburgh, Pennsylvania. You had to feed the meter. All right, Andrew, we're waiting on you.
No pressure, Andrew.
No pressure, no pressure. No time pressure. We just have a lot to get.
Yeah.
Lots to discuss. All right. So welcome back, everyone. We are going to continue our discussion and we're going to move to discussing Garner Health. And Andrew, I understand you're taking the lead.
Yes. Very much. So this is a topic that we talked about last month. In addition, there were lots of very detailed conversations at CL, which Greg and Kimberly and Andrew all participated in. So good to hear their perspective on things as we proceed through these slides. And so we've broken this content down to show, sort of revisit on, well, what is the solution, number one? How do the savings work? How does Gartner identify top providers? What does member access to those top providers look like? Health equity review, and so we'll talk through that. We'll talk through member experience, and then we are going to have a demo as well. We've got a couple of folks from Gartner here in the room with us. And so the demo really kind of brings the whole thing to life. So I think that'll be a good use of 10 minutes or so, or however. So let's start by moving to the next slide, and I'll do a quick recap on what it is that we're talking about. And so Gartner is a quality navigation tool that members can engage with to search for top providers. And then if they go and see one of those top providers, their out-of-pocket expenses can be reimbursed. And so, so that's at a very high level what this solution intends to do. And so by steering folks to these high quality and efficient providers, their member health outcomes are improved. There's greater transparency that's being put in the hands of members in terms of quality, not having to rely on Google when you need to find a certain type of provider. And then there's savings both for the member as well as for the plan. This works in the intended way. And so let's jump to the next slide, and we'll take a quick look at how are savings being driven by this solution. So here we've got two tables. The top is a per employee per month perspective, and the bottom is just an annual aggregate perspective. And so the proposed incentive design here is 1,000, 2,000 HRA incentive. So that means 1,000 for members enrolled in employee-only tier, $2,000 in eligible incentive dollars for those enrolled in dependent tiers. The HRA is the tool through which reimbursements are distributed. So that's a health reimbursement account. It is a tax-preferred account that Gartner would administer, and Gartner would be sending those incentive dollars to members. And so moving to the next row, you can see the idea here around savings is that there's claims savings associated with these top providers. Because they're high quality, they have better outcomes, because they're efficient in their practice patterns. To the extent that members can be steered to those folks, it actually reduces costs for the plan and for the member. There is a Gartner administrative fee, and so this is the amount that Gartner requires for the solution, as well as the $11 for MODA and Providence. That's the projected HRA funding. And so once you net out those two expenses from the $46 and $44 in claims reduction, you can see the net savings on a per employee per month basis, $30 and $28. So you apply that amount to the populations enrolled in MODA and Providence, and you can see how that translates into an annual savings amount. And so this is the way that this is being proposed is sort of purely as a carrot approach. And so there's no penalty for members who don't engage with Garner. This is really just a sort of enhancement for those members who do use the tool and get reimbursed for their out-of-pocket expenses with those top dividers. Garner is willing to guarantee a savings rate. Savings rate is about half of the projected savings here. And so the sort of caveat there is that Garner does require that 30% of members use the tool. If 30% of members use the tool, they will guarantee all of their administrative fee. If less than about half of those total expected savings, in that dark purple row, less than half of those savings are achieved, Garner will refund the incomplete administrative fee back to them. Any questions on that? Yes, Sean.
They'll refund the administrative fee if 30% of members use the service. Is that the idea?
If 30%, use the services and a minimum savings threshold is not achieved, of roughly a little over $2 million for MODA and a little over $5 million. Yes.
And just a quick clarification, that 30% is just a sign-up rate, not utilization, not members actually seeing the providers there. It's just 30% sign-up is the threshold.
That's great. Thank you.
And this was vetted through the innovation workforce, yes.
CIAO, that's right. Yeah, that's right. However, CIAO doesn't look at this type of content. So CIAO doesn't look at the fees and projected savings. But we did spend a lot of time talking about the member experience and top providers and equity and access. And so we've taken a lot of that analysis that was done there and made it a little bit concise for purposes of this meeting. But given the sort of potential impact for a program like this, we thought it was important to share this with the broader board.
Yeah, in terms of savings, there are some white papers talking, I think some other documents about how savings happens. And through the Margaret, we talked about this on one of our meetings about like vetting, at some point also, if this is implemented, vetting the savings estimates, to make sure, see what's impacts of it, the types of savings, the number of members care was redirected and things like that. And that would be potentially through. So, in terms of the performance guarantee, that sort of analysis would definitely be done on our end to make sure that, they are being demonstrated in this case.
So I guess let's proceed into the next topic. And for this, I'm going to hand it over to Dr. Twang on the Mercer team to talk about how does Garner go about identifying these top providers.
Thank you, Andrew. Good morning, everyone. So there's really three key elements to identifying the top performing provider. And from the member's perspective, it's really about viewing and accessing the Garner app. Each time there's a referral or a need to start seeking care or treatment. So it's requiring that individual to access the app, input a condition or provider, and basically viewing what Garner presents and identifies as the top performing providers. Behind the scene, there will be tracking. So selecting one of those providers by making an appointment, following up with care, that will be sort of reconciled by Garner in terms of the financial. But for the member, it's really just about every time they're thinking about seeking care, finding a physician, start with the app, and then the system will track who they end up seeing. Now, behind the top performer score, the performance score is really based on the integration of quality and cost, and it's based on a large set of metrics, about 530, and they continue to research and grow that. And it's based on about 75% of the available claims history across all different plans nationally. And the criteria is really to find within a set of providers that provide care for certain conditions, sort of identify that top tier that based on their quality metrics and cost, factoring in access and other factors, which ones are sort of the top performers. There's about 89 specialty classifications that are covered through this methodology. Next slide. So let me dive into the selection criteria. It is really the intersect of quality and low cost. And the premise is knowing that when we as providers approach care, there's just a practice pattern that we bring to the equation. And that can be gleaned by looking at claims. And that practice pattern translates to things that are optimal, some things that are inefficient, some are unnecessary care. So those are sort of the broad buckets that we call quality. And by looking at quality, that leads to value, because then it's getting the most clinical outcome for the amount of money that was spent. And that achieves the cost, the low cost. So when you sort of find those two dimensions for each provider and you kind of put them on a graph, what Gartner is going to do is kind of seek out that top left quadrant, which they call the top performing providers. So those are your top tier for those care for the specific conditions or procedures. Listed are just some examples that you may be familiar in terms of what things may be variables that physicians make that may or may not be impactful to cost, to clinical outcomes, but do have an impact to cost, right? Ordering imaging, when, how often, where did you order that from? A good example. Using conservative treatment options before jumping to the most aggressive and typically costly surgical interventions, etc. So at the end of it, it is bringing two things, helping the member have transparency, right? A curiosity as to what matters to their clinical care. But ultimately, it's them having a choice based on how that information is presented, if they choose to go to that provider or not. And then the financial impact is the refund on the out-of-pocket. Next slide.
Actually, one comment. So, the types of things that are being brought up here, they're in alignment with the work, with the COEs, trying to bring in the COEs and the efficient, high-performing providers. And like the third bullet, the fourth bullet, right, and the fifth bullet were things that we were trying to achieve through the COE. Like finding the providers who are not going immediately to surgery, taking a look and doing the right things, practicing well and doing the lower invasive procedures before getting into the surgeries. And there were definitely difficulties around just identifying it. Gartner, has a data set to identify it. So there's definitely some trust behind, who, or, trust, we're going to talk about it, but, there's definitely data behind the quality, and Ian's going to talk a little bit more about that, but, it's like having that, identifying who the providers are, having that set of metrics and making sure that everyone, understands and is comfortable with it. That was a big issue with the COEs. And this is what's being taken care of here, as well as the member experience and just, incentivizing the member to get to those providers. And with the HRA, that definitely helps, which was like an issue with the COEs. It's like, how are you going to implement the COEs? So it's a lot of things that we were trying to do in terms of getting that more efficient providers, better care is kind of.
And we do think there's going to be openings with those providers, because I thought that was one of the issues.
That is always brought up as an issue. It's something that we're looking into. The PEB and the web's big, but it's not the majority of the population, the majority of the services in Oregon. So, depending on the providers, maybe there might be some who are definitely having, just overbooked or really busy, but, we can have, I don't know if you want to talk about how Gartner identifies openings and making sure that the members, have access to, who they identify actually have access. But, it is an issue, that gets brought up, and it's an issue that we're kind of trying to keep an eye on, but I don't think the volume of services is such that it becomes a bottleneck. And if it does become a bottleneck, there are ways to find providers who are also high performing that are available. I don't know, Andrew or Ian, if you want to speak to that.
Yeah, so when a provider bills a plan and they've seen a new patient, there's a CPT code that gets captured for that. So what Gartner does is if there's a top provider that's been identified, but they're not in receipt of that code that indicates that they're actually seeing new patients, they won't show up in the search results. And so Gartner's methodology will, if there's a top provider that's shown and then all of a sudden there's this influx of volume from PEBB and PEBB members, if they're no longer seeing new patients, they will drop from the search results. Did I get that accurately? Okay.
That's correct.
Yeah.
Third time, question, okay. So I'm just, quality, like how are we defining quality? So is that culturally competent providers? Are those linguistically appropriate? I'm just wondering if they can, screen or disaggregate by culture or language, for example. And then with the cost part, I think I mentioned this at the last meeting, but I learned so much from these national webinars with people with disabilities. And, to manage their care and children with disabilities, it's more expensive. But they argue that it's a good investment. Like once they have the providers that work for their family, it might be a little more expensive, but it's good for them. So I just wanted, to make sure that we're being mindful of people with disabilities. Just, the top provider may not work for them. And so anyways, yeah.
Yeah, I believe those are all valid points, and those are things that we've had discussions with Garner about. I'll speak to the clinical, and Christy will address some of the things that she's looked at it from the equity and disparity lens. And some of these things will come up in that update. Next slide let me just cover the clinical perspective, clinical / more the medical aspect of it. Obviously the top tier factors, state license and all that. These providers are within the MODA and Providence network of providers. So what we're doing is working within the established network, and then further analyzing on the left side, so the quality metrics break down into two categories. So when we approach care, there's just certain things that are optimal or typically ideal to be performed in context of care. So these are protocol measures. Corollary of that is some things are probably unnecessary care. We've done it just out of habit. So they're also looking at those. So if you think of those are broadly protocol measures, as they call them. And some examples there are, for example, appropriate testing before you make the diagnosis. So you're not just guessing, half the time, unless it's a clinical intuition, it's not a hard confirmed diagnosis. That's kind of the world where clinicians often live in, but there's certain things that are just best practices that we want done. Similarly, evidence-based approach to certain procedures, like using evidence-based care for what Emery was commenting about, like for joint replacements. There are just criteria for an optimization for minimally invasive, better recovery, better patient experience, lower cost. Not as convenient for the physician who can just sort of do everything through a big count, right? So those are things that they measure and they quantify. So the bulk of the measures fall under these protocol measures. The more complicated ones require risk adjustments because we're looking at utilization intensity and outcomes. So we really want to know how sick or how severe that condition is. So they sort of mine the data, look at multiple data points to do that. Some of the factors that get incorporated are age, gender. So they're crude, they're incomplete, and they acknowledge that, right? So the number of confounders are always going to be more precise, but you're kind of constrained by the data. But they realize they're going to try to expand on that and looking for more race, ethnicity, disparity, potentially social determinants in health. They're using third-party data sets, what they've communicated to me, to start to see how to unearth for the coordination. On the cost side, it is really based on those decisions. There's a consequence on cost. And a lot of these things are partly based on those decisions, but part of them is just where you end up going. For better, for worse, the contracts that are negotiated, some things are just higher one place than others for no other reason than going to place A versus place B. So they've accounted for that. So there is site of care, pharmacy utilization cost, procedures and surgeries, and other things, and just the negotiated cost per service. So it's the aggregate of this coming into a formula that rolls up into a performance score that you'll see in the demo that is presented to the member. And viewing that is sufficient. Obviously, they have to follow through with making the appointments. But Gartner will track who they end up seeing, and if they're seeing those top performers, the financials will follow. Questions about that? That's a quick overview and on how the measures get calculated. Andrew, you want to cover the access?
Sure.
Question?
So if we could jump to the next slide, please. Excuse me. So we did spend some time doing some analysis around what does access to these top providers look like based on where you are within the state and outside the state. The way that Garner defines access is very similar to how MODA and Providence are defining access, so that was good. It's a starting point. But when we did our specific access analysis, what we found was that those areas of the state where there is an access issue to top providers essentially mirror the known network access issues that exist in certain parts of the state. So in the Northeast, in the Southeast, and in the coastal region, primarily where are the most access challenges related to top providers, which again mirrors known access issues again amongst the broader networks for MODA and Providence. Largely because in some of those very rural areas, there just aren't certain types of providers. In those instances, members are having to drive farther than the access standard to be able to see a provider in person. And so one of the things that Gartner does, which is helpful for trying to maintain equity of access, so that there's no scenario where all the top providers could be concentrated in Portland Metro, because what Gartner does is they look at availability within a specific geography, and then determine top providers based on providers within that area. And so so it doesn't improve access. It's not any worse than what is in place today in some of these very rural parts of the state. One nice part about the incentive is that any virtual visits with top providers are eligible for reimbursement. So to the extent if you live in a rural area, you can do a pre-appointment or a follow-up appointment virtually. You sort of save yourself from doing a long drive, and those virtual visits are all eligible.
All right, yeah, so hello, everybody. So our health equity work group also has done a deeper dive into Gartner. And, using our framework, we really focused on the 4 areas that are on the left-hand side here. We sent questions through the carriers to the Gartner team. And so you can see here, we've outlined, the first column, there's some positive elements in each of these categories. We've identified some areas of opportunity, and then also wanted to provide what Gartner's response is here. So I'll just try to quickly go through these, but member experience, a couple things that our group, as we looked at their answers and looked at, having our discussions, is that, there is a choice of whether to use Gartner or not. So it's not steering, to a network that has to be used. We do know obviously high quality care does reduce complications and adverse events. And then having that financial incentive is also a positive for members. Some areas of opportunity that we have uncovered is, obviously we know that communication and member education around Gartner is going to be crucial to it being successful. So just want to highlight how important that is. It really is up to the carriers on how we're integrating the Gartner tools in the website and the apps, and how we're going to really, again, make it easy for members to access that. Currently, there's limited customer service hours for the Pacific Northwest. As you can see, Garner has said that they'll look at adjusting those so that we can meet our members' needs. Cultural responsiveness training for customer service staff, again, understanding PEB and having that training in place is a crucial component. And then also offering that language line. So Garner has English and Spanish available, but wanting to also have language line services available for people who speak other languages. If I look at access, a couple things. Again, high quality providers is a really positive. They do also make third-party calls in that provider availability, in addition to that CPT code monitoring that they're doing. So those are positives. Obviously, we've already highlighted there is the potential, for these already challenged areas. And they have like a maximum wait time of 12 weeks in place for if a provider is surfaced or not. So if from those two components of the third-party calls and the CPT code monitoring, if it indicates that that provider doesn't have availability within a 12-week time frame, they don't surface them, but that does not fully align with our other access equipment to wait time standards. And you can see Gartner's response there. One of the areas, and Emily, this goes back to your question, is kind of that provider congruence. Right now, there's limited search functions for finding a provider. They do have language search capability planned for 2025. But one of the areas of opportunity, and I know that they do have concierge assistance for helping members find a provider that meets their needs, but currently there's not a search capability for race, ethnicity, LGBTQIA+ experience, and other preferences. And then last,
So for language though, is there English and Spanish capability, but not for like Vietnamese or Mandarin or Cantonese?
Exactly, and you can't search for it. So somebody couldn't go in and say, I want a male provider that speaks Cantonese and have that come up in that specialty right now. Yeah. And then last thing, when we looked at that top provider methodology, so Dr. Twang's already covered a lot of the positives that they're doing. And then there are, again, some, currently the algorithm does lack kind of that incorporation of looking at race, ethnicity, and cultural responsiveness. Again, Emily, what you had kind of mentioned, no mechanism to address potential bias in that algorithm, obviously without that information, and then lacking explicit analysis or bias testing for those race, ethnicity-based variances. And so Garner this is on their roadmap. They are, looking at monitoring bias, getting that real ESOG data from carriers. So it's the future state. Any questions about initial health equity deeper dive?
Great. I think in the interest of time, let's do the demo. So I'm sort of foreseeing that we might be tight on time, and so 10 minutes. I don't know how long the demo takes. Okay.
Want me here? Is a better place for the room?
Wherever works
Okay.
for you.
I'll try to project here.
Okay.
So let me go ahead and share my screen. So what we are going to walk through today is what that PEBB member experience would be in accessing the Garner platform. So as we mentioned, there's a few different doors that people could enter in order to get to Garner. Part of that is integrating directly with MODA as well as with Collective Health, both conversations which we are currently underway. But once people access Garner here, whether they're downloading the app directly from their phone or going to the desktop here, this is going to be the experience that is going to be the same across the board. So we want this to be very clean, simple, easy to understand for members. And there's just a few things that I can do in order to search for and access that high quality care. So first and foremost, we know that most members are going to spend most of their time in the self-service search and finding a provider. So there's a couple different things that I can search for. I can search for a provider name. Let's say I want to see if my PCP that I've been utilizing is considered Garner recommended, or maybe I know that I need a cardiologist. We also use natural language processing for members that don't necessarily know what type of specialist, if they're just searching by a condition, symptom, procedure. I think we'll use the exact same example that we did for the COUT group here, and I'm experiencing back pain and I'm based in Portland. So we'll click to find providers. Obviously, for something like back pain or, hey, I've got a stomach ache, we want to send people first and foremost to a high quality primary care. But once they clicked that they've seen that high quality primary care, what's going to come up is a list of providers that follow a few different rules. So first and foremost, all of these providers are going to be within network, whether it's that MODA or that Providence network. We're never surfacing recommendations that are out of that network. Next, all of these providers, to Dr. Twang's point, we know are outperforming their peers from both a quality and a cost perspective. So this entire list here is what Garner would recommend as high quality providers, non-surgical orthopedists within that network. Now, this is all I need to do as that member experience is just perform this search here, and I can go see any one of these providers. All of my out-of-pocket expenses are going to be reimbursed up to that incentive level that we set with PEBB. So for instance, let's say I wanted to click into Dr. Christ. I can read a little bit more about our performance methodology for a very interested member. Why are they getting this 96 score here? You can see that we do take into consideration things like publicly available patient reviews, the distance from the member, but ultimately all of those 530 metrics are going to bubble up into this area. So diagnosis, treatment, outcomes, you can see we're looking specifically for back pain. We might be highlighting a different non-surgical orthopedist if I had searched for knee pain or shoulder pain. So very condition specific and specific to that episode of care for the member. Next, to the question around equity as well, we're surfacing what languages this particular provider speaks, their specialties, location, and then availability and access is a big portion of why we're recommending this particular provider. So I know that when I call to schedule that appointment, they are accepting new patients and have upcoming appointment availability. Now, the second way that I can choose to receive care here and to interact with Garner is by utilizing our care concierge team. And really want to make a note as well that this care concierge team would go through the appropriate trainings. They would be dedicated specifically to PEBB in how they serve your members. And they would also have the capability to warm transfer between Providence and between MODA. And if there are things that Garner can't answer, sending them to those care coordinators on the carrier side as well. But whether I'm calling in, we have a dedicated phone line. We also have the ability for members to message the concierge team, as you can see here. This was a real example. I was looking for a provider for my wife, got a recommendation from a friend. Looks like that provider was not considered high quality or Garner recommended. But what that concierge was able to do was find 3 other recommended providers that, again, in network, upcoming appointment availability, outperforming their peers on cost and quality. And then any of these providers that I go and see that are recommended, all of my out-of-pocket expenses would be reimbursed. Now, the last thing that I wanted to show just from a user experience standpoint here, again, we want this to be really simple. We also want this to be something that is supportive of your entire ecosystem and all the benefits that are available to PEBB members. So just as an example, here at Garner, we have access to Bend Health for pediatric behavioral mental health. So when I search for that applicable term, that third-party resource is going to come up first and foremost. Same thing with other third parties, benefits that PEBB members have access to. We want to be able to route into that experience and increase adoption of those things that you want people investing in as well. Now, the last thing that I'll highlight, you can see that for some of these providers, they do have the option to be seen virtually and to schedule online. So that is a capability here, especially within behavioral health that we have prioritized and is expanding for other specialties as well this year.
Live example,
This is
can you put in 111?
111 as a zip code.
Alameda Court, no, 97882.
And now one thing that I do want to call out, this being a demo dummy account, it's not based on the underlying MODA or Providence network. So if we're seeing some access issues.
Okay, no problem.
And what was the zip code again?
97882.
9782. Click to find providers. We're just looking for a primary care. You can see the list of providers that comes up.
Okay.
Again, we're looking at this based on distance. Some are 6 miles away, others are going to be 20. And this is work that we've done at length.
This is our normal,
Mhm.
that's normal for us. And
So
then the other thing I was going to ask is I have Providence Choice. There are certain doctors that I cannot see. Is that when I put in my name, address, phone number, I tell you that I'm with Providence Choice, I cannot see anybody at OHSU.
Correct.
Does that sort that for me, or do I have to sort that?
You wouldn't have to do anything as a member. That's all information that we would integrate directly with the carriers. And so you logging in for the first time, we know the network, the plan, the providers that you have access to.
Follow-up question. So let's say that that first question, have you seen a primary care? So let's say that you did go to a primary care doctor and they looked at whatever, the ankle or whatever you're doing. And they were like, oh gosh, that looks bad. I'll give you a referral, right? I mean, that's typically the way this works. And you think, okay. But then you go on here because you want to do the thing and they give you a different person because, they refer to their friend or whoever.
Sure.
So how's that work? Because now you have a referral that your network thinks that is who you should go see. That's who you're approved to go see. Versus now I'm just making my own, I went to this. So like, how does that work with the network?
So any of the recommendations that Garner is making would again be within network. So kind of under that auto approval status. So for any sort of net new episode of care, for that referral, I'm searching out a new type of provider or specialist here. We would strongly encourage the member to utilize Garner to search for that particular episode of care and see one of our recommended providers. So in that scenario, searching for that name, for that referral, or just searching for the care type and seeing one of the specialists that we're servicing here.
But I'm pretty sure that we have conditions in our book where you have to get a medical referral to go see the specialist, no?
No. Not anymore.
Yeah, it was removed. It was
It's the only time, because I've done a few times now, because I have Providence Choice. The choice has always been you have to have a referral. We removed that. The only difference is I did call one doctor and I asked and they say we require a referral. Then you would have to get a referral. Other than that, I can make my own, as long as they're in the plan, if they're in the network, I can call, like I have a shoulder problem.
Yeah.
I just went right to Tri-Cities Orthopedic. I didn't go see my doctor. I didn't spend an additional $1 for me. I didn't spend an additional $1 for the plan. I went straight to Tri-Cities Orthopedic. It fixed me. It was covered. And I didn't need a referral because they don't ask.
And that's true for Mona too.
Yes.
Yes. Yep. That was I don't know, what was it, 3 years ago?
Yeah, I think it was
24.
24, yeah. It was a suggestion brought up by Providence because it was something that was brought up as a member complaint or members complaint.
Yeah.
It was getting those referrals for a lot of people, and that's when we removed those 2 years ago.
All right.
So backing off of that, could you put like acupuncturist?
So there are certain specialties that we do not service, things like acupuncture and chiropractic, we would not. And the reason being, we are very evidence and literature based, and it's just a matter of the evidence that's out there from best practices for those specific providers. But anything outside of acupuncture, chiropractic, and emergency services, so every specialty from PCP to neurosurgery, we would be able to service here.
It's a strong evidence base for acupuncture. And so Johns Hopkins Medical School, like, so we're just curious if there would be more movement in the future in including acupuncturists.
We're always looking at expanding those specialties, so that's certainly something that we can take back to our product team.
Okay. And then also just, I've brought up an OBGYN example here before. I, in another state, was when I was pregnant with my child. And I was looking for an Asian OBGYN, somebody who was familiar with my traditions in childbirth, which are really different from Western medicine. So at that time, which was 2000, the year 2000, they didn't have that capability to go through the directory and find a provider that was familiar. But what they told me I could do instead was I could call providers and ask how much experience they have delivering Asian babies. And so I'm just wondering, like, would you all be open to like including that type of info in your search?
Yeah.
In the near future?
The short answer is absolutely yes. And the only reason that it isn't currently searchable in that way is just because of what data is publicly available. So we know that not every provider office includes information around race or ethnicity or, LGBTQ ally status, things like that. But that is a perfect case for our concierge team. They would actually do that additional work. They would search through the provider websites in order to make the recommendations for that member.
Okay, and thank you for bringing up LGBT, QIA2S plus. So our youth are, incredibly vulnerable right now. And, our workforce, we have family members, children, and, who identify as LGBTQIA2S plus. And so it's really harmful if they go see a provider that is not friendly and open to that. It can actually put them back. So is that something else that you can explore urgently, including in the search?
Absolutely.
Okay.
And what we're doing right now is anything that's related to a CPT code. So think, for instance, gender affirming surgery. That would be something that is currently searchable that we can report on. If it's a little bit more broad and, hey, I'm looking for a PCP that is an LGBTQ ally, again, that would be a perfect case for our concierge. And we're exploring with both our MODA and Providence partners on how to better integrate a lot of that information too.
Awesome. Thanks.
Thank you.
Yeah, so,
Yeah, the only thing I wanted to bring up is a few things from CL
yes.
that we kind of had fleshed out. And as we said there, nothing against Garner. We think it's a good product. The thing we have to do is messaging would have to be huge because as John said, I'm sitting in the doctor's office. They now say, in these specialists, I know, talking to my, yes, in talking to my doctor, which I saw my doctor, Mr. Altman is, the first one there because he's closest. Would he know who these Garner individuals are? If not, he gives me someone, I then have to say, no, I want to use this app. Not that it's wrong, but we have to make sure our members decided that's what they want to do in order to save these dollars, save us those dollars. Number two is that the other thing we talked about is that one thing that OEB's not doing that we are is 27, we're moving to maybe a brand new product. And so, as again, I said, nothing for Garner, but do we want our members to do a 1-year trial of something that may be here next year? So those are just the two things that I wanted to bring those up. Those are just the two things that came out of kind of that meeting that were kind of large that we really need to think about when we're doing this. I think it's a good product. I think it's something that would be used. It's just those two scenarios and maybe something to try. It may be integrated into our 27. And if so, this is something that we would, want to make sure that we get a good handle on if it does stay with us in 27 moving forward, but just something to think about.
Thanks, Greg. And Andy's not here or at least available to comment as well. She's on CIO as well, and she abstained from voting whether to recommend it or not. Just want to put that out there because I think she again doesn't have the ability to weigh in, but I think she felt a lot better after going through the demo, but she didn't want that to be known.
Well, I think, Greg, I think you and Kimberly voted yes.
We did vote yes, because I think it's something we need to look at. I think that's a good, like I said, I think as far as working for our members, something that could, anytime we can put members back in their money back in our members' pockets, and anytime that we can have them see even though it's Garner's choice that these individuals are a better surgeon, if data shows they are, or they're a better doctor, then that's where we need to, get our people to. So I don't have an issue with that at all. Just we're kind of in the middle of some flux. And, it's just one of those things that the 30%, we would, sign up. We probably could have people sign up. I don't think that's an issue. And so I think we could probably do that with just with good messaging. But then, I would hope people would use it, but it's just that remembering when you're sitting in there and you're going through that traumatic time that you need to now, and if not, like you said, even after I come home and I'm like, oh, I have X, I could try to use, as long as there are no issues from my doctor giving a a referral and me then deciding to go this direction, as long as there's no, it's seamless to go from one to the other, I don't see a big problem.
So Greg,
Those are good questions, you know?
yeah, it is, there is the potential for disruption, right? Because the RFP is hanging out there and
Well, changes always.
and changes everything.
It
It
doesn't matter
changes,
what-
changes disruption.
You change one.
It was not something we wanted to start out with. We had to come up with the game plan with board leadership to basically just status quo, but then the results came in. And this is a program that isn't reducing members' cost sharing, right? It's improving members' cost sharing. And so that is, and as well as trying to reach some of the goals, the aims of the triple aim and everything with what PEB wants. So, it is, you do have to take those into consideration. It is a benefit. So maybe hopefully that, isn't as disruptive, right, to the members.
And I will say that OEB voted 100%. They were very, very happy with the product and on board as well. So. Okay. Just take it.
But no, yeah, that's right.
I wanna
Yeah,
make sure.
that's right. Yep. Okay, I think in the interest of time, we might want to go back to the slides and jump to the scenarios. So there were a couple of slides that we skipped over, and so we can jump back and refer to those as needed after we sort of orient you to this slide and get your take on some of these options. And so the way that we've structured this, as you can see, there's 20 or so different rows that all have varying amounts of cost reduction associated with them. Some of these are about efficiency, some of them design change, reserves is included here as well. Our negotiations are influencing our starting position, our 68 million that we're starting to, that's our sort of starting point that we need to solve for. And so we've got 4 scenarios here to really just sort of generate discussion and get board members' reaction. And so 4 scenarios, and the first scenario relies the least on reserves. And so as you move to the right, the scenario relies more on reserves. And so you can see in the top row that there's $30.7 million needed to achieve low-cost plan status based on the current projections. And then if you look at the bottom row, there are additional reserves based on the scenario. So the way to think about that in scenario 1, since you see there's not an X next to the 30 million, there's only $25 million in proposed reserve dollars in that scenario. For the others, it's really the 30 million plus 5.7, 30 million plus 10.2, et cetera. And so we have added this pink box around a scenario that we think makes sense. But as we've sort of alluded to, I think we lost the slides. As we've alluded to throughout the presentation, there's different ways to do this, right? This is a balancing act. And so we wanted to create this at a minimum as a sort of starting point to get board members to react to and talk through. So scenario 2 that we have circled, for the most part, there's not a lot of plan design change. There are some tweaks to how the plan designs would work. So things like mail order pharmacy, a mandatory mail order program, including a retail 90 option for Providence and Moda. So that is on there. We also have an X down towards the bottom there for some Kaiser benefit change options, which we didn't get to, but we can certainly jump back to after folks have had a chance to react to this. And so under scenario 2, I guess I'll start there. We're assuming the buy down to achieve low cost plan status. We have an X there around a change to the Aetna wrap network associated with the Moda plans. There isn't a savings there, but it is a decision the board will need to make. But I think we can set that to the side for now. We have put an X next to eliminating the 1750M incentive, to adding Garner for Providence and Moda, mandatory mail and retail 90 option for Providence and Moda, and eliminating Nurse Line, which is an administrative efficiency that we think makes sense. There's not a ton of savings associated with it. That's one of those slides that, again, we had to skip over, but we can circle back to after I pause for reactions here. And then option one, Kaiser plan design changes to bring some parity between some of the co-pays and the Kaiser plan designs with the managed mode and Providence plans, with about $1.8 million in cost reductions associated with that. And so the other sort of piece of this equation, which I think we can speak to an extent here, and there might be some follow-up, is around the reserve target. And so we've talked about that. Emery talked about that a little bit at the beginning when he was providing the financial update. We do have a slide after this as well that maybe we can just flip to it so folks can get a quick glance at it, that shows what happens to the stabilization fund based on these scenarios. So Emery, are there any other comments you want to make on this slide before we ask board members to react to the scenarios?
Yeah, so this is taking a look at the fund balance as of where would be after 26 based on the different scenarios. So the one on the left basically is if you just buy down all the reserves, buy down with all reserves, and that has the lowest fund balance because basically you're not making any plan design changes in order to meet the target. And then scenario one, which has the most plan design changes, has the highest balance because you are cutting essentially the most benefits in this case. Scenario two, the one that we had boxed around, so a little bit more of a balanced approach, kind of like almost equal between using reserves and plan design changes. And then 3 and 4 has a little bit more reserves in this case. If you do, the reserve target currently is at $306 million based on the plan options. So, and it's going to be about that level depending on whatever you do, somewhere pretty close to that. There's been some discussion, discussing what the reserve target should be is something that we can have. It's probably a little too hefty for this conversation right now, but the reserve target, as mentioned earlier, is designed to essentially have a buffer to account for claims coming in higher than what's projected. And so, just trying the financial safety of the PEBB plans, and that's really what it's there for. We talk about maybe trying to protect over 2 years because underwriting cycles 2 years as we use 24 claims for 26. So there is the uncertainty in 25 and 26 that might happen, in terms of the costs, underlying cost utilization stuff that might impact that we wouldn't be able to account for until next year's renewal. So there is 2 years of uncertainty that we're trying to deal with. But when we're talking about overall uncertainty for a plan of the size of PEBB, due to just random fluctuations in claims, we're talking about maybe $50–60 million in fluctuation there. And so that is well below the 200 million. But then we have the other issue where, with the trend, whether if we underproject the trend, and so how would that impact that? So if that's another 5%, we are talking another 60–70 million. So if that's over 2 years, we're talking maybe 120 million or so. So that on top of the 50 million, let's just say in uncertainty, gets you about 170 million. So if we're talking about these certain levels, even with using all the reserves, theoretically, you're okay for 26 for covering any sort of uncertainty by just buying down. But that does put you in an issue, actually for 27, where you have to make some really big cuts in order to have enough funds here. If you make some plan design changes, that will add to the cushion. It will reduce the trend and expected cost for 27 as well. With Garner or any other efficiency, there is probably an ongoing efficiency with lower trend if as more and more members get used to it, use it, and go to more efficient providers that hopefully will reduce the trend and result in fewer cuts needed for future years, right? And that's the hope of the RFP as well. That and potentially, there's mentioned earlier with Providence and collective health, there's some potential outstanding savings there, potentially through utilization management that aren't really reflected in the cost. So there is a little bit of a buffer potentially to maybe use a little bit more reserves and then anticipate savings from the RFP in 27. So any of these scenarios would you'd be okay, at least protected. You would be below the reserve target, but you'd be okay in terms of making sure that PEBB is not likely going to have to ask the legislature for money because there's just no money in the stabilization fund. Just wanted to kind of lay that. Ollie?
I was just wondering, can you maybe express like an estimate of the 250 million in percentage terms, like
Yes.
1 percentage point equals 10 to 12 million.
Yes, so, so this is on self-insured, basically, Kaiser's about not quite 300 million, so we are talking about $1.2 billion in self-insured costs. So 1% is what, 12 million, so 10% is 120 million. So scenario one gets you about 20% of your self-insured costs for 26 anticipated. So so all of these are around that 20% threshold right now.
And then the other thing, I don't know if you mentioned, but the other thing, like before, when we did the RFP, those first couple of years, you can maybe, you're able to set, you're able to set like what it's gonna go up, where you're gonna be, and that may help us as well in that fund going forward.
Yeah, I mean, that's the anticipation, right? I mean,
Maybe, and it's
yeah,
it's an out there.
it's an out there, yes. We are hoping for some additional stability and additional savings as a result of RFP, better performance guarantees, more stricter performance guarantees. Yeah, so I mean, there is the hope that in 27, we can talk about potential lower trends, better admin, all of those things, better contracting to help reduce the need to cut, to meet the 3.4%.
It's also worth noting that probably unlike any of your other clients, like we have an extra risk, which is having too much money. Because if we overshoot our target, we get rated by the legislature. So we actually have this really narrow window that we have to meet, which is not too low, but not too high. And it's kind of like we have to thread this needle every time. And so I think what I've learned over the years is that there's at least as much risk going too high and being too conservative, so to speak, in terms of like fiscal caution, which otherwise would be perfectly reasonable. But in our case, there's sort of like this ceiling that you get your like head cut off if you go above. So there's also that. So I've been kind of wondering if we ought to have like a slightly lower target over time anyway, just because I've even at certain frustrated moments even been like, maybe we just shouldn't have self-insured at all because they're just going to come rated. But
From the 99 they took, this
not-
would be easy.
right. So not
Only 60.
going that far, just saying like, we maybe should think about a slightly more, a slightly lower, long-term target, just because we also have that risk. And it's not abstract. This has happened. How many times have they done this?
Yeah.
Three, right?
Yeah.
I wanted to say two, but I was like, God, I think it's three.
There's one that was.
Yeah, so 3 times they've done this. So it's not a like, oh, maybe in some point, like we have learned, like they're gonna do that. So anyway, that's just also part of the
Yeah.
discussion when anytime we start talking about stabilization fund targets. You gotta remember there's 2 risks, there's 2 sides of the risks, too high, too low. So.
Yeah, just one point on that target, right now you are showing potentially that you're below the target. If you do reduce the target, you're gonna be closer or potentially you're gonna be above the target, and that might be construed as surplus.
Right.
So I just want to ensure, make that point.
No, we understand.
Makes sense.
Like I was saying, if we had the 99 that we just lost, this would be.
Yeah, and it's much easier discussion when it's like, oh, yeah, we have whatever, like 99, or
So we.
was over 100 million a year.
Prior to, we get that money, we could have used it easily. But now I'm definitely on track with what you're saying, Sean.
Yeah, and the funds coming in, their compensation, right? So their compensation that's been slated for the members, for the employees of PEBB. And that is part of the overall benefits package. It's in there to pay for claims, and now so it's got.
With what Sean brought up, revisiting maybe a board policy around the target would be a good summer kind of topic. So far this legislative session, there was nothing included in the governor's recommended budget that would take from PEBB, but that's not how it happened. last time, so.
Right.
So, yeah, it could be, there's gonna be some significant funding shortfalls, upcoming, so.
Exactly, like, things could get bleak in a hurry and all of a sudden, like, gosh, there's an account somewhere, $150 million. Wow. So like, yeah, it happens, so. Anyway.
Should we talk about the Kaiser changes in our narrative?
I guess looks like that. So there are two optional Kaiser medical plan design changes here. And so option one, which is the option that we would recommend, again, brings parity between Kaiser and the Mona and Providence plan with regard to the office visits for specialists and PCP. So you can see that the current copays are very low at $5. You know, these plans have historically been overutilized. And so while on the one hand, you know, we obviously always want to be really careful about plan design change. Indexing the fixed copay from 5 to 10 might be enough to sort of adjust that dynamic of overutilization of the plan. And again, it would bring parity between Kaiser and the managed plans under Mona and Providence. Option two drives more savings, but it introduces pharmacy changes, which are disruptive for members and create a lot of noise. And so, you know, our recommendation would be to consider option one as one of the potential savings.
And we did do cost shifting with Kaiser last round.
I believe we did,
Yeah,
yeah.
on
I
the-
don't have that
With the
right
prescription drugs, yes.
prescription, yeah.
Do you remember? Can you remind me what the?
It was like, was it $0 or $1 and like,
I think it went to from 0 up to 5.
yeah, 1 to 5 and then,
Yeah.
was it, I can't remember.
Bring it more in line with the other
Yeah.
two plans. Yeah, that's what we did last week.
Yeah.
You know, it's not a huge savings, but it, you know, it's, you know, as Andrew mentioned, you know, it does kind of bring it in line with the other plans and the, it's, there has been more utilization. I mean, Kaiser, you know, is utilizing services in Kaiser has been quite high, typically, more expected than Kaiser does for book of business. So, it does bring it in line with that choice in this case.
The only other one I had a question was the HEM, doing away with the 1750. If we decide to do the HEM, we would still get the lower deductible, the lower full cost out of pocket, right?
That's right, yeah. So members would still have to do the HRA and their incentive would be the low.
Right. Yeah, that's right. I just want to make sure.
Kimberly's hand was up.
Yeah, Kimberly.
Hey there, sorry. Hey there, I was just wondering, can you let me know how many of our employees this change in Kaiser Permanente? Can you give me a head count again? I can't remember what the Kaiser Permanente numbers.
Yeah, so the number of members on Kaiser, it's about 10,000. 10, 11,000 employees, if I remember correctly. It's in that ballpark. So 26,000 members, something like that. So we're not quite, it's like 15% or so. No, it's more than that. It's probably close. It's not quite 20%, but it's a significant chunk. Okay.
So some definite communication plans would have to be put into place for these kind of changes.
I just have a question. Do we even look at the deductible plan staying the same and tweaking the traditional plan? Because that's the plan that most people are on. And I
Yes.
know in the past, I mean, that's now the most expensive plan, right, that PEBB offers, the traditional plan. It's more expensive than Providence statewide. And I know in the past with Providence statewide, we had done tweaking of that plan prior to Providence Choice, for example. So I would just ask that we look at that, because the deductible plan, we have, you know, much lower cost on that plan, the one. And maybe the deductible plan.
Yeah, we can definitely get that information. It's not something that we had. Okay.
So just calling our attention to a time check.
Yep.
And acknowledging, we are going to need to make some decisions at our next board meeting. So board members, although we are out of time for today, I encourage you to go back and look through your notes for today, look at the information we have, get any additional questions that may be generated, get those answered. The team is available.
Happy to meet with anybody, whatever you need, we're here to support you.
In order to be able to come to some final decisions at our main meeting for this renewal. And with that, do you have any closing remarks for this section?
No, this was kind of the slide we've been really working towards. You know, we do have a next step slide. We've kind of already covered. I guess the only additional comment I'd make is that, you know, we're talking about the renewals, but we do want to call your attention to the RFP. We are working on that quite a bit behind the scenes. And so that the tentative release date for that is July this summer. So that's the date that we're working towards. But like you said, you know, work towards decisions in May. And then that would leave June to just do a quick sort of final approval of rates. Just generally pretty easy thing. That's our timeline as we look into the next 3 months. The activities.
Thank you. And I'll look forward to seeing if that's on email, right? There's no more last minute accommodations at this point. All right. Okay.
So, yeah, I just want to, you know, I appreciate Mercer's all, you know, and the staff's, everybody's work going in. I know you've been pressing on it. And, yeah, I appreciate the offers. You know, there might be some ideas between now and next meeting that we will have some additional questions, I suspect, from some of the board members and what have you. So, yeah, just appreciate it. Keeping moving forward.
Thanks, Sean. All right. To move on, Glenn Bailey, are you here?
I'm here. We were gonna do, we're just gonna do it with.
Sorry.
It's in the packet.
Pause on that and do the public comment now. I think. Okay. It looks like the board will be reviewing the legislative information in the packet, the details, some of the details are there.
And if you have any questions, do feel free to contact us on legislation as well.
Okay. And then, let's move on to public comment. I will remind our commenters that this is an opportunity for you to share your thoughts with the board. There will not be discussion at this time, but we certainly will take your comments. We're listening and we will take your comments back for consideration. And I welcome Ms. Carissa Anderson Horvath. Are you with us?
Yeah.
She's here in the room. Very good, Sam. Welcome.
If you like.
So this is not the first time I've come. But my point of being here is I've had to deal with a huge amount of medication issues that have come up through the MODA this year. And I wanted to make sure the board understands a lot of the issues that are actually put out there by some of these changes. I have asthma, comes up during the winter when I get sick. Went to the doctor, went back to get my Flovent, which I have used, use it very little and use it when I need to, not a large amount. I was rejected. Went through the whole doctor said she really needs this. No, rejected. So they put me on another one. I have been on that one for 3 months. Still is not working. And if for me to have to go through 3 months of not being able to breathe right,
and have to get my doctor, who's already busy. Now I'm seeing a pulmonary specialist, which is now costing all of you so much more than it would have for me just to be able to get my flow vent, to be able to figure out my stuff. At the same time, I just did run a half marathon. Why I could barely breathe. Taking my inhaler, which I've tried to go to a new inhaler now too, because it still makes my heart race. But these have become the fact of even showing that I am trying to be fit, trying to be healthy. And these are becoming harder and harder to get because for some reason, someone has decided these are unnecessary. After talking to my pharmacist, I'm not the only one. And then a month later, I get migraines, which I've had every once in a while, usually use Advil, naproxen, none of them worked. So I went back to my doctor. I don't take opiates, not because I'm worried about getting addicted. It kills my stomach and I wouldn't be a good person anyway, but that's the last thing you want anyone to take is an opiate. So Naloxone, which is the highest grade NSAID out there, it is not available in any shape, form at all without prescription. I was denied and said it is not at all available. So my next step would be getting an opiate. So thanks to the decisions made, if I wanted to get relief, I either have to pay out of my pocket or I have to get an opiate to be able to get that under control, which is not where we want to go. And this day, I'm a biologist. I understand these things. These are not great decisions to make. So I paid out of my pocket for it. And the crazy thing is I have a double coverage. I'm actually covered by TRICARE. TRICARE covers all of these prescriptions that MODA is not. But because MODA will not cover them, it's rejected by TRICARE because it has to go through the tier. So the bad decisions made on that continue costing me because TRICARE will reject anything that's been rejected by the primary. And I don't know if anybody knows what TRICARE is. It's military insurance. It is the bottom of the barrel insurance. It is what I'll end up with when I retire. But when TRICARE is giving me better coverage than MODA for my prescriptions, that is very sad. And that to me is, and I went to talk to the pharmacist about this. She was, this is becoming a headache. This is common. This is new this year. I don't understand why it's, and they have a new pharmaceutical person there. And she was trying to explain to them how Naloxone, why they're not covering. She said, it makes no sense, but they're just saying that she could take more Advil. Yes, I could put a hole in my stomach too. And I take Naloxone as little as possible. I've even had to take before, when the migraine got really bad, and they are going away. It's an injection, which is an extreme ibuprofen. Took one of those, Trojan or something like that. It worked. Nothing I can regularly take. And nor can I take Naloxone for long periods of time, nor is it meant to be taken for long periods of time. But during that period of time, it did get me through extreme migraine so I could sleep, so I could work, so I could function. But these are the things where these aren't expensive. And what I got from MODA was, oh, you can use your discount card and get it for $20. Why do I have so much coverage so I can be told to use a discount card? Why is the state of Oregon? I mean, I pay for this, I'm an employee, but the taxpayers pay for this. They really do. And for me to be told to go use a discount card, and I tried to get answers. What I was told, it was your guys' decision. You made the choice to not cover these medications. To no longer carry Naloxone because I could take ibuprofen, there's something else. And your doctor could find something else. Well, my doctor is a very intelligent man. And he sits there and for a long time trying to, little by little, get me to this. And he's like, well, this is the best I can do. It's not covered before it goes to an opiate. So you've left me with either paying out of my pocket or getting opiates. And I mean, I think that right there is a really sad decision on that part. So I'm just wanting everybody to understand that some of these things that aren't really big things to most everybody else end up having life-changing issues to people. I mean, I'm an active person. I am heavy, but I'm an active person. I run half marathons. I'm going to the gym all the time. I'm a wildlife biologist. I'm hiking 5-6 miles in the woods. But when I can't breathe, and I'm still after 2 months not being able to breathe, again, I'm going back to the pulmonary specialist. That is going to cost everyone here. Why? Because I couldn't get a prescription because the formulary is no longer covered from Flovent. And I would have been done and off of it by now. But these are the decisions that really are costing you more money. Some of these are really necessary and they've been used for long periods of time. There's reasons why pulmonary specialists push for these certain drugs. There may be other ones that kind of work or work for some people. But if my doctor, who is mean, pretty intelligent. He's went to school a lot longer than I have. Tells me this is what I need, and everyone in here is telling me my doctor is wrong, and I can try something different. And he has already wrote a rebuttal against it, still got turned down. So I can go over and over and over again, but you know what that is? It's a waste of my doctor's time. To fight everybody in this room is a waste. The waste of his time. It's a waste of me going back and talking to him, because every time I go to him, it's a cost. It's me taking time off of work. Cost to everything. So sometimes finding solutions that you think are going to save you, I always tell people it's like not upgrading to giving someone a program because you can use it off someone's computer. You know, that itself takes 2 hours to be able to do the extra work to it. You're not saving it. You're adding cost. You're adding pain and suffering to people's lives. I mean, it's well documented. I mean, I don't have asthma most of the time, but when I get the inflammation in my lungs, the bronchial inflammation, it does not go away until I go through. I already went through a whole bunch of, what do you call it, prednisone and everything else. It helped. But the one inhaler that I've been taking for years worked. The new one I'm taking, which everybody says is the same, I'm still not getting there. So I tried to go through the things. I went through the system and I got shut down at MODA. Basically I was told by you this is the way it is, and that I'm just gonna have to sit there and fight it. And I was talking to my pharmacist about it. She goes, you need to push back on this. This is so common and no one seems to care about the person behind it. You guys are saving money. I understand it. We need this. We need all these things to work. We also need to know that some of these penny pinching points are not beneficial. And I will say, I listened to the whole thing today. Please don't cut the second thing for x-rays. I would hate to get punched in the face or get hit falling down and break a tooth and need to get multiple x-rays and get stuck paying for those. Those are expensive. I mean, I have sleep apnea. I use my sleep medication every night, everything I'm supposed to do with my nose, everything. But if I have to go for a sleep study, I have to save up to do that. So those are things we're already adding. If you're doing things right, you shouldn't be punished for it. These are people trying to do the right decision. These are people like, hey, if I need to have another sleep study in a year, hoping that I can maybe get off of it, or maybe there's a change they can do. The cost is ridiculous. It's easier for me to keep having you guys buy $1,000 or $2,000 machine. So
Thank you for bringing.
thank you. Thanks.
Thank you for those comments. We will consider them, take them into account. Those issues of formulary decisions are really important decisions. They impact a lot of people. And they are within the powers of some of the concerns represented in these negotiations. So thank you for bringing those comments.
I can just say the INSEAD decision is very recent. We'll gather some data and put a report back to the board together very shortly and to Carissa.
NSAIDs being non-steroidal anti-inflammatory drugs. That's the reference to ibuprofen, also known as Advil, and meloxicam, which I think is another one that was mentioned. Okay, thank you. Is there any other business for today's meeting or anything for the good of the order? Hearing none, thank you very much for participating with us today. We'll look forward to seeing you next month. Have a good day. This meeting is adjourned.